non-surgical DME, that is non-tractional, non-center involving DME. You see, so much has changed in last couple of years, both in the diagnosis as well as management of these very common disorders. You see, and this generation has seen it all. We all began with virtually no treatment for AMD long time back. Then came era of PDT and TTT, and we were so frustrated. In fact, patients could not improve. Then came this injections era, and also in diagnostics we started with fundoscopy, then 90D examination, angiography. Angiography, OCT, then Octa. Also, the visual prognosis has dramatically improved. So diagnostic modalities have improved. The therapeutic armamentarium, so many things are there to offer, and visual prognosis also has improved in all these conditions. And believe me, this is not the end. This is not the end. And a lot of things new are happening. And every day, virtually, we hear so many, results of this study coming out or other study coming out. And I personally believe there are very, very exciting times we are all going through. And this scientific meet on retinal vascular disorders has been organized under the guidance of Professor Rajvardhan Azad, the president of SAO, South Asian Academy of Ophthalmology. And he is not physically with us, but he has agreed to address this audience online. So I'll request Professor Azad to give his inaugural address.
Thank you very much, Lalit. And at the outset, I would like to thank all the speakers and the audience for, on behalf of the South Asian Academy of Ophthalmology, that we have started a new kind of academic activity, for our South Asian, friends. And I must thank, it will be befitting to thank Dr. Lalit Verma, a very proactive and a very dynamic person, and who has, organized this meeting. Of course, I am on the Zoom because of my, personal reasons and official commitments. I will quickly catch up from where Lalit just now said. You may not have seen those eras when there was no treatment for NAMD and also for diabetic retinopathy. Of course, we had laser, and laser used to, give results equivocal this side, that side. And then the era came, the PDT era, somewhere in 1999, 2000. I just returned from Kuwait, and this PDT had started. And PDT also used to give good results, I must confess. And I must tell you, Lalit was at that time with us, Lalit and Dinesh. And we used to do, I have done almost 11 PDT in a day for porphyrin dye. And then gradually 2008 and 2007, this anti-VEGF came. Of course, Avastin was there. Avastin was being used off-label. But then Lucentis came in 2008, 2009, and we started using Lucentis. And Lucentis used to give good results. And gradually, from Lucentis, we landed up with aflibercept. And then we landed up with the biosimilars. Biosimilars have come in a big way, like, Ranizurel is there, Rani-I is there, Ranibizumab is there. And, now a new, this thing, not new, I should not call it new because we all are using it, Brolucizumab, and, is what we call as a Pagenex. So Pagenex has come in the market, and we are all using what? As Lalit said, that we are, the treatment is evolving, and from no treatment, we have reached to a stage where we have, lots of very promising drugs are there. And these promising drugs are giving good results, like, of course, ranibizumab or these, the eccentrics. They are the baseline drugs in the management of NAMD, diabetic retinopathy, venous occlusions, and several other diseases related to retinal vascular, conditions. And the recent one is brolucizumab. I don't want to take more time because lots of speakers are there. Earlier I thought of, showing my slides, but then, because of several reasons, I could not make it. But then I just want to tell you that some of these drugs which have come very recently, they are very good drying effect, and not only drying effect, with preserving the photoreceptors and the vital elements of the retina. In fact, I am so impressed that, I was even thinking, that if instead of giving 3 doses, if we just give 1 dose and, do the PRN after 1 dose, I think that will be a kind of not only economical for the patient, but also for the physician, in the sense that once the response is very good, then you keep on watching the patient, and then you feel that you are comfortable, and also the patient is comfortable. So I was just trying to give this message to all my friends, and of course I have couple of times I've talked to Lalit also and many other my friends who are using these anti-VEGF, that the time has come when we should, of course, the pharma company will not be very happy, but then, we have to go on a clinical judgment and clinical experience. And our clinical experience says, at least I have felt that some of the recent drugs, like Pagenax, you give 1 Pagenax and the retina is flat. And not only flat, it remains flat for 6 months, 9 months, all the way. And therefore, sometimes it comes to your mind, is it relevant, or is it, what you call as a kind of ethical on our part, that if once the retina is already flat, then we need to inject more, say 2 injections or 3 injections more. But then, we are all dealing with science. And because we are dealing with science, we need to, have some scientific evidence. And if we have this kind of evidence, we can shift to this new kind of paradigm of management. I'll request all our friends who are participating in this, webinar, and the physical one also. So I'll request people to, if you have data where you have given 1 injection and then you have a result, say 6 months, 9 months, and so on and so forth. If we compile all this and then make a presentation, I think that will be something very informative and something very economical and something very interesting for our world. So with these words, I close now, and I will be very happy to keep watching, the entire, the process of this webinar. So thank you very much. Thank you all who have come here and who have come to listen and who have come to exchange your ideas. And I am here with you. Thank you very much. Thanks a lot. Lalit, thank you very much.
Thank you. Thank you, sir. Thank you, sir, for this inaugural address and also pointing out that we should all compile our data. So we begin with our first session, and I'll request Dr. Manisha, the chairperson, to please be on the dais. And along with that, Dr. Neeraj, Vinod, Ruchir, please be on the dais. So first session is being chaired by Dr. Manisha, whom we all know. She has done wonderful work for VRSIs, and she is continuing excellent, work not only academically, but for so many surveys and all she has pioneered. And she, is chairperson at Shroff Charity Hospital. And we have panelists, Neeraj, Vinod, and Ruchir, who have abundant experience. We have 7 talks in this. We are deliberately not going into the diagnosis and various trials and RCTs, which all can be Googled and, information can be there. Our focus for this meeting primarily will be real world experiences and how, people are getting results. And you see, anti-VEGF agents, we can broadly divide into earlier and newer generation. Earlier means Avastin or Lucentis or ranibizumab and aflibercept. Now, newer generations which have come up is brolucimab, then faricimab, then 8 milligram aflibercept. So these three are promising from the point of view of extended duration. All of them promise around 2 to 3 months or maybe 3 to 4 months duration. Ultimate aim is the burden on the patient is less and his visits are reduced. Ultimately, costing gets reduced. If the costing gets reduced or if the patient has to come less frequently, I think the compliance improves. If the compliance to any treatment improves, then the results also tends to improve. You see, once we were giving monthly injections, then patients get fed up and he may not come as was shown by Luminous trial, that 50% of patients drop down, they don't come. So with these newer drugs, the compliance is bound to improve and so are the results. So ultimate aim will be to talk and discuss how we can employ all these agents judiciously so that our practices and our patient care ultimately improves. So with these words, I'll hand over to Manisha for taking the proceeding forward.
A very good evening to all of you. And at the outset, thank you, Lalit sir. So without any delay, we'll start the first session on neovascular AMD. And with me on the panel is Dr. Neeraj, Dr. Vinod. I can see Dr. Ruchit Tiwari. I think Dr. Tariq has joined online from Bangladesh. So we will now invite our first speaker of the session, Dr. Raja Narayanan. And Dr. Raja Narayanan again needs no introduction. He's a very senior retina specialist from LV Prasad Eye Institute, Hyderabad. And he would be speaking to us on neovascular AMD, treat early and treat aggressively. Over to you, Raja.
Yeah, thank you, Manisha. And thanks to Dr. Azad and Dr. Lalit Verma. In fact, Dr. Azad almost gave my talk actually, the way he spoke, in the sense he introduced it very nicely. So a lot of my introduction and the challenges that I will speak will be kind of what he has already spoken. While I'm delighted to be speaking again, I have given this kind of talk many times over, but it feels unfortunate also that why should we be talking about a pattern or a protocol repeatedly, even 18 years after the start of anti-VEGF treatment, that treat early and treat aggressively. Is it new? I'm sure all retina specialists agree that this is not a new topic. So what is new about this? But unfortunately, there is a lot going on. This still has to be repeated. Maybe our communication is not correct. But yes, there are some myths. There is a lack of clear understanding of AMD's natural course. What happens for 6 months? What happens after 1 year or 2 or 5, 7 years? Data is there, but unfortunately, the understanding is not very clear. What happens to AMD if we don't treat? There is a lot of undertreatment going on at this point of time. It's a number one cause of poor outcomes of AMD. Not that treatment is not available, but there is gross undertreatment. There are various factors for that from the patient side, from the clinician side. There is also a lot of wrong opinion going around by non-retina specialists, which ultimately some retina specialists also give into. And the most common thing is that there is no use of giving injections because there won't be any improvement. Now we have to look at these things. While we may not be LASIK surgeons, we are not cataract and LASIK surgeons. We don't give 6x6. We don't promise 6x6. In fact, 6x6 or 20x20 is an exception or rare bonus, but we prevent a lot of blindness. We prevent as retina specialists. We may not give 6x6, but we don't let light perception or hand motions also come in. That's something which we all should remember, including non-retina specialists. And importantly, Dr. R.V. Azad has already said new drugs have come, which will reduce the burden. But nothing can be solved, even if injections are available. If the doctors keep on saying that it's of no use giving the injection, then whatever medicine, treatment, injections we have is not going to work. This disease is very chronic, as we all know. So CNVM is only a sign. It can be due to various diseases. This is a compilation of various conditions where you can have CNVM, ARMD, high myopia, inflammation, and many others. And this is just to say that, okay, in all of them, we give the injections, but they all carry a different prognosis. And what is that? In cases of some categories of CNVM, the course is very long. You have to give over many years. In some, you give the injections maybe 2 months, 3 months, it's all over. The disease is well under control, never comes back. But based on OCT, you have 3 types of CNVM. One is under the RP, one is above the RP, which we call as type 1 and type 2, and intraretinal is type 3 macular neovascularization. And there is a difference between these 3. So the occult CNVMs on FA are typically the type 1 under the RP, and the classic ones are above the RP, which are classic on FA. And if you see what are the causes, ARMD is mostly related to the occult or type 1 CNVM. And the implication is that most type 1 CNVMs require a very prolonged treatment, long course of treatment. Myopic CNVM, inflammatory CNVM, you may give 2 injections, 3 injections, maybe over. But ARMD CNVM, it has a long course. This is a point which everyone has to take notice of, that when you communicate to the patient, don't tell an ARMD patient that I'll give 3 injections and we will see, or after 3 injections, it is most likely to be over. No, even at the end of 1 year, this patient will probably require injections. This is the kind of communication that has to go out. Because if you give any space for a patient, 3 injections or 3 months, and I will see, the default for a patient would be that, yes, I will be all right. He may say, or doctor may say for some patients, but it won't be me. And once you enter the 4th month and you say, you need 1 more injection, the patient will just go away to another doctor or may not come back to anybody. Now, what have the various trials shown us? Why are we talking even today about early, treat aggressively? Is that if you don't treat these patients, the Marina trial and the earlier MPS studies had shown what happens to these patients if you don't treat from the control arm. So if you see the control arm, that is in the Marina trial, it was sham injection. No treatment was given. If you don't treat, you see how the black line is going down and down and down. That patients lose vision. So as I said, we are not 6x6, 20x20 specialists. But if we treat, at least the patients do not lose vision, may gain some vision, but do not lose vision. Whereas if we don't treat, patients do go blind. So that is one thing we should remember. And even the earlier molecules were not very effective. They slowed down. But the problem with quarterly injection, now peer trial was after 3 loading doses, it became quarterly injection. And even if you just give blindly quarterly injection, in fact, some patients require even monthly injections for 7, 8, 9 months. Now we are having better drugs, but if you just close your eyes and say, come every quarter, they also actually lose vision. After the first 3 injections, they'll start losing vision. So this shows that this disease requires continuous treatment, absolutely over long term. So far what we have realized now in the first few slides is that we can tell our patients that ARMD CNVM is a chronic disease. You may gain some vision, but the main point is to prevent further blindness, and the number of injections is going to be significant in the first few years, depending on the injections we choose, but anywhere between 5 to 7 injections may be expected in many patients. So recently, we have had newer treatment molecules, as Dr. Azad was pointing out, that if we can get one injection and then it's all done, kind of, we are coming closer to that probably, but not yet there. So the thing is that the newer drugs, brolucizumab or even faricimab or even Eylea 8 milligram, which is coming up, they can give us prolonged duration of action. This is from the Hawk and Harrier trial, brolucizumab. As you can see that these patients maintain vision even at the end of 1 year, even Q8 week and 12 week. That means once in 2 months or 3 months. So the number of injections required can be significantly reduced. Same with faricimab, the number of injections required, especially in the PTI phase, personalized treatment interval phase of the second year, only 3 injections in the entire year. Again, what a wonderful news. There are other myths which we need to be aware of, we should be careful about. Now, while intraretinal fluid is definitely more harmful than subretinal fluid, that means if a patient has just a little bit of subretinal fluid and no intraretinal fluid, he is likely to do better in terms of visual outcome compared to someone who has intraretinal fluid and no SRF. But the point is that SRF is not something to be tolerated. Now, there's something which has come into our mindset that SRF can be tolerated. Now, that has to be understood properly. When we say tolerated, it's in the treat and extend protocol where even dry retina is not tolerated. Remember, in treat and extend protocol, even in dry retina, when there is no fluid, we give injection. It's just that the interval is extended slowly and slowly up to a maximum of 3 months. So when we say there is only SRF and no intraretinal fluid, it doesn't mean that it is tolerated and we stop giving injection. All it means is that we still inject, but you can extend the interval between the treatment. So the tolerance in SRF is that you can extend the treatment, but it's not withholding injection. You never withhold injection in the treat and extend protocol. Now, this is again for IRF versus SRF. Even in the other trials, brolucizumab, we have shown that it is IRF is much more dangerous than subretinal fluid. So the current challenge, as I said, is with the number of injections or the duration of injection. And in that context, I will be showing today one case of brolucizumab. But the main thing to remember or know about brolucizumab is its very, very small size. So small that it has almost 5 times the penetration into the RP. And that's why Dr. Azad also mentioned in one injection, many times you get flattening of the fluid in these cases. 26 kilodalton, and it easily penetrates single chain variable fragment. And what it showed in the trials is that more than 50% of patients tolerated Q12 week dosing, which is very good result actually, once in 3 months. This is a case report we recently published where even the polyp regressed on ICG at the end of 1 year. This patient required 3 injections. Initial 2 injections did not regress the polyp, but after that, the polyp regressed and it remained regressed at the end of 1 year. Now, this picture I'm showing from a friend of mine who had asked whether to inject on the left-hand side a patient who is having 6/36 vision. And I had to clearly explain that if we don't inject in these patients, because it looked very less fluid, it looked like, maybe chronic cyst. This is not chronic cyst, this is active intraretinal fluid. You must give injection, and this is something which we must be careful about, that if the patient is tired and the doctor also starts behaving like a tired patient, and we say, okay, we will see, and this patient is lost. And so the point is that if we give up early, and if we start thinking about patient, oh yes, it's a huge burden, whatever gains we have had in the previous months of repeated injection will lose in 3 to 6 months. Everything will be lost. So in conclusion, patient is never old to be let go blind. Many patients or doctors say, Umar ho gayi, he's 80-year-old, dena hai kya, should we give? But then we must be clear that patient, if he has been able to come to the clinic and hospital, patient is active in life. So they should be able to given the full life that they have to live. So treat early, we all practice, we all are aware. Nobody comes with a fresh air and then no doctor says that you go back, it's of no use. We all do that, we treat early, treat aggressively. Most of us practice, we don't say that I give one injection and you don't come back again. We treat aggressively in the first few months, but treating continuously, that it becomes a problem. After the first 3 months, we start giving up or we start slackening a little bit. We have to look at the patient as a whole, that we must maintain and fight for the gain that we have got. You cannot keep on expecting improvement in vision every visit, but to maintain that improvement is so difficult, and that is treat continuously and treat till the end. It's a chronic disease, never give up. Second year, third year, if it is required, you must give the injections. And we cannot lose track of any of the above points. And we should be very, very transparent in our communication to our patients. So overall, I would say that treat early and aggressive is something not new, but I would just reiterate that don't give up and never let these patients go blind, whatever we have got so far. And fortunately, we are getting new treatments now, which can be given much less frequently. So thank you all very much for your kind attention.
Thank you, Raja. I think you've beautifully covered all the aspects of managing cases of neovascular AMD. If there are no questions from the audience, I have one question for you. When you say you are treating aggressively, when would you really decide to say, okay, this is the amount of fluid I'll have to live with in this particular patient? What is your criteria for deciding to do that?
Yeah, that's a very good question. And since this is ARMD, there may be other protocols for other diseases. In ARMD, I don't tolerate fluid. I don't tolerate any fluid. So if it is dry, many of my patients are on treat and extend protocol, because treat and extend protocol means you don't tolerate, you give injection even and then the macula is dry. But we all agree that, okay, in India, it's very difficult, it's not an insurance system for many of us. It's very difficult to tell a patient also. But what I do is, for 1 year, if the patient's OCT has been dry on treat and extend, then I start looking at, okay, treat and observing the patients, looking at a PRN option. But if there is fluid, there is no tolerance. There is zero tolerance for fluid in ARMD.
Any questions from the panel?
Thank you, Dr. Raja. That was a very enlightening presentation. I just have one point to make. See, being a young retina specialist, I don't have as much experience as you. What exactly do you mean treat till the end? Because I have not seen any cases end till now. I've been practicing for the last 7 years in my private practice. None of my cases have ended.
Yeah, so again, very good question. So what Dr. Manisha asked and what I have told, let me just reiterate how it may end, okay? How not every case may have an ending of dry macula lifelong, but we have seen patients who have remained dry for many years also. Now, when you have fluid, you have to treat. It has not yet ended, okay? That's one thing. So if there is any fluid, you have to treat. But then if there is no fluid, that's the time when you start thinking, is this the end? Can I end it now? How far can I stretch it beyond? Now this, you can have two different ways of doing it. One is the treat and extend protocol, which I had been talking, that even there, I don't tolerate even dry macula. I keep injecting for 1 year. If it is dry, I switch to PRN. Now, when you can switch to PRN, so when we switch to PRN, what it means is that initially also it has to be a monthly visit. Now in CAT trial, we all know that, it was monthly injection versus PRN, both were similar. Now, if you have PRN, be clear that PRN meant monthly visits. So if the patient is having dry macula, you still can call the patient monthly and it stays dry. It's kind of, an end result. But you say that, okay, but I still need to have a frequent follow-up. So these are the two ways in which you can look at the end game for this.
Yeah, Dr. Raja, I think one more important thing to be kept in mind is visual outcome. if the vision comes out to be around 6.9, 6.6 also, even if little bit amount of fluid is left, would you go for treatment? Or if the fluid remains for 2 consecutive injections same, but the vision is stable, so would you like to wait and watch, or you will try to dry it up completely?
Yeah, so this is again a very good question, and thanks for asking this question. And this is where I said it is very, very disease dependent, your question. But if it is ARMD, zero tolerance, no study, no evidence, in fact, has shown to the contrary. If you have intraretinal fluid, this patient will go down in ARMD. But DME protocols are different. They have shown that even if there is fluid and you don't treat after a certain particular time point, no harm is done. But in ARMD, if you leave fluid, then these patients will go. So let us be clear that, that's where I said many people are talking to different things to different patients, that, patient has reached 6.9, I don't want to inject, even if there is some fluid. I am very clear, please don't do this as long as you know what disease you are dealing with. If it is RVO, DME, yes, there is some tolerance. But in ARMD, there is zero tolerance.
So I think I'll take just the last comment from Dr. Talwar.
Thank you, Raja. I think you put the things in a very good perspective and highlighted the need of the aggression or the eternal vigil, as I call it, for AMD. Now, the question which you asked about ending, there are two endings. One is when I die. This is the counseling I give to the patient. You see, it's not nice to tell a patient till you die. So I tell the patient that you do treatment till I die with me. And then when I die, please find another ophthalmologist. So it makes it very clear to him that this is for life. So the first point is treatment continues for life. But treatment may not mean injections for life. It may mean follow-up for life, injections when needed. This is point one. The second thing is, when do you stop? 6.6, you don't stop. But counting finger 1 meter, you may decide to stop. So the end point, there is a visual end point, and that comes when you're less than 3/60, and it's the better eye. That's the second part of the stopping of the treatment. The third part of the stopping is in dry, when the lesion becomes dry. If you've got 2 sequential 16-week follow-ups with an injection, say a treat and extend, being given 16 weekly, generally you can say that, okay, we are not giving you any more injections, but 3 monthly follow-up will continue lifelong. So even when you have a dry AMD, a dry lesion, the follow-up now becomes from monthly to 6 weekly to 8 weekly to 12 weekly. But 12 weekly follow-up is mandatory for life, because what looks to you, and I will show you some cases, looks to you as healed can sometimes come back. Even
Very nicely said, Dr. Talwar. Totally agree with you that follow-up is part of the treatment. You can never stop the follow-up. That means treatment still goes on. And what you said, it's not the higher limit of vision when you stop injection. It is the lower limit. When I die, you said, I mean, as an ophthalmologist, I say either the macula dies or the doctor dies. So even if the macula is dead, you stop treating. Yeah.
Thank you, Raja, for a wonderful talk and comments by everybody. I think we'll move on.
Yeah.
But one thing is very sure, NAMD you treat for life. DME, like Raja said, you can, heavens are not going to fall if DME you do not treat very aggressively.
So I think we'll move on to the next talk by Dr. Dipender, and he would be speaking to us on clinical experience of brolucizumab in CNVM in India, a multi-center retrospective study. So I think till Dr. Dipender is getting ready, I think the points which have come up from the last talk is that we have a zero tolerance for any kind of a fluid. And only when you have the evidence of a scarred CNVM with very poor visual acuity is the time when probably you'll stop. The patient has to be on a regular follow-up, and then you treat whenever there's a recurrence of fluid.
One more point I'd like to make. See, everyone talks of treat and extend in terms of dry lesion. That's not true. You can have a lesion which has become stable, but is not drying any further. And that could be not just SRF of less than 50 micron or something. It can be intraretinal cysts also. You can reach a point where the cysts are not changing in morphology or size, you can reach a point where the SRF is not changing in morphology or size. Now you can extend this lesion, the treatment from 4 weeks to 6 weeks to 8 weeks. And as long as it remains stable, that is the limit you need for injection for this patient. So we tolerate fluid when it doesn't go away.
Sure.
We don't accept fluid just because fluid is good. I mean, SRF is not good.
Yeah, Dr. Dipin.
Very good evening, all of you. And at the outset, I'll thank Professor Azad and Dr. Lalit, sir, for inviting me to present this very small study, which we did under a banner of Delhi Retina Forum. And sir, actually forced me ki you should come and present because it might bring more interesting discussions on today's topic. So our idea was first to see that can we do a multicentric study with our kind of resources and platform. And second, the drug itself has generated a lot of attention after its launch. And we have seen a lot of colleagues presenting good examples of this drug being a very potent drug and long-lasting drug. So we wanted to see that, let's see how it's doing in India in real world. So that was the whole idea. And we had no financial, I think, interest or any conflict of interest. The only information we took from the company was who are the early users of these drugs and who are doing high volume, work on this drug. So that was the only thing which we, the information we sought from them. And it was, of course, a multicentric retrospective study. And based on the previous similar studies, for efficacy and non-inferiority designs, you need almost around 200 patients. So our plan was to just see if we can get 200 odd eyes or 200 patients to evaluate this drug. Inclusion criteria were very, I think, standard. You all know this, all AMD trials, they have similar criteria. Only thing what we wanted was that we will include only those cases which have at least 6 months of follow-up. And time for enrollment was right from the beginning, April 1st, 2020 to 31st April 2022. And we wanted to see 2 years outcomes. Exclusion criteria were also very standard. We excluded anything which could have confounded our anatomical or functional results. And this study was presented to our ethics committee in December. In fact, we wanted to study the criteria which are not studied in routine trials. But when we presented to ethics committee, they wanted very objective outcomes to be evaluated. So we ended up getting same outcome evaluation what a conventional trial does, like BCVA outcomes, anatomical outcomes. So we'll be publishing this study, and after that, we'll do subgroup analysis and try to extract more useful practical information out of this data. So in nutshell, 11 study centers, these were the centers who have participated in this study. And this was the study performer. We tried to capture all practically relevant information through this retrospective study. And so at the end, we could enroll 331 eyes of 309 patients. So you can see almost 11 patients had both eyes enrolled for the studies. And all these eyes had 6 months of follow-up after first injection. Of course, mean age was 67.8 years, and male females were quite well balanced, 46 and 54%. Etiology of CNVM, there were 3 eyes which were also, data was sent to us, but they had CSR, myopia, or MACTEL. We excluded them. But if you see, majority of eyes had neovascular AMD, and around 15% were PCV patients. And similarly, if you go to anatomical classification, 24% eyes had PCV, 30% had pure type 1, and 14% had predominantly type 1. These were all categories. We listed them for our all study participants, and they had to choose among these. Sometimes it was not well defined. So again, 4% were ill-defined macular neovascular MNVs. This actually data came as a real surprise to us. Because most of us in northern part and in our practices, we started using this drug mainly for previously treated patients who had high injection load. But this data came to us as a surprise that in our study, 54% eyes were actually treatment naive, and which was very interesting outcome of this study. 39% eyes were phakic, and out of that 10%, that is 13 eyes, underwent cataract surgery during 2 years period. We tried to compare with multiple tests the visual gains in eyes which have undergone cataract surgery versus phakic eyes who had not undergone cataract surgery. The difference was not significant. So cataract surgery had not influenced our visual outcomes. We also tried to see how people are working up these patients, what is the practice pattern. And again, a little more surprising that 64% eyes FFA was done. OCT, of course, was done for almost 100% cases. Octa was also done for almost half of these patients, and ICG, again, it's not gone out of use. Especially probably, what we could make out is that because our colleagues were using this new drug on patients, maybe they were more cautious and they were, doing more elaborative kind of workup with than a general medical retina practice. Now, this was again important data that the mean number of injections given to these 331 eyes in this 2-year period was 3.55. A total of 1171 injections were given. And you see many patients have received more than one injections. 277 patients received more than one injection, and 176 patients actually have received more than 3 injections. So that means they were fairly well exposed to this drug. And as far as, again, this was again a very important area of interest, what treatment protocol our colleagues are following while managing these neovascular AMD patients with this new drug, and with the kind of information which was coming, especially at the start. So again, you see PRN and loading followed by PRN dominating the list. If I club them, almost 87% of patients were managed with PRN, and but only 34% patients, people were using loading dose. But most of these, I think, patients were being treated with PRN. Treat and extend was not very popular with this drug at that time. Only 4% eyes being treated with treat and extend, and of course, others variable. Again, this is a category we introduce for real world study because sometimes the treatment interval is not exclusively guided by physicians, discretion. It's actually patients also choose. So we were discussing about tolerating fluid. Sometimes your patients also start tolerating some fluid. They say, okay, I'll hold. Let me see if my vision drops. Yes, I think everybody made a point. Don't undertreat them. Another thing which we wanted to evaluate was how much injection-free interval can we reach with this new drug. And again, the mean injection-free interval, which is more important, was around 19.7 or 19.8 weeks, which is again very encouraging. And if you see, more than 12 weeks of injection-free interval was reached in 84% patients, more than 16 weeks in 70%, and 54% patients could achieve a treatment-free interval of 20 weeks. But again, I like to emphasize, this is one-time achievement. It's like your, a one-time high jump record. You have jumped 6 meters, 10 meters. It's not that they were doing consistently. So that's what would be our interest in like future with when we are planning this extension study, that how many of them could persist at that high injection-free interval for a long time. But if you see one time, I think this was the data. BCVA, again, it's a real-world study. We converted ETDRS visual acuity to logMAR and then logMAR to letters. But this is what we could get was 17 letters gain at 6 months and almost 15 letter gains at 24 months in all eyes. And if we segregate and try to analyze treatment naive eyes, they were expected to do better, and they did. 19 letters gain at two years follow-up, again, quite encouraging. Yeah, I will also have to highlight that if you see the number of eyes available for analysis were not 100% eyes. If you see here also, out of 331, only 321, 318, and as we go for 2-year follow-up, the number of eyes available, having data, relevant data available, it goes down. And again, anatomical analysis, central subfoveal thickness, again, you see very good reduction in central subfoveal thickness, almost 221 microns gain. improvement at 2 years follow-up. Again, at the bottom, you can see the limitations of a retrospective study. We also recently, because we have now with submitting our manuscript, so we did a fluid analysis, and I think we had a discussion just before this talk about fluid. So subretinal fluid, intraretinal fluid, and the sub-RPE fluid. So they may not signify or indicate similar this kind of disease activity, but what we could get at 6 months was around 45% eyes had almost none or minimal SRF. The minimal SRF terminology was used by a couple of centers to define SRF, which was less than 50 microns. So we could get that 45% at 6 months, and you see at 24 months, almost 55% of these eyes were almost dry. So this is again a learning which came out from this retrospective analysis. But if you see, this is again a very interesting thing. 28% eyes, even at 2 years follow-up, had intraretinal cystoid. This is much higher than what Hawke and Harrier have reported. In fact, they have a very good post-hoc analysis published in Ophthalmology Retina, where they have evaluated this persistent fluid patients and tried to find out more information. So data there is around 14% or even lesser. So we got it higher, maybe because we had a combination of both previously treated and treatment naive eyes. And this was again a very keen area of interest for all of us, that what is the complication rate in Indian patients. So as far as reported by all our study centers, 6 out of 331 eyes, that amounts to around 1.8% was the incidence of intraocular inflammation. And if you calculate as per number of injection, it was 6 out of around 1100 injections. Only 5 out of 11 centers reported IOI, and there were 2 cases from 1 center and 1 case from 4 centers each. But none of these patients had developed any retinal vein occlusion or occlusive vasculitis. We cross-checked them this twice with them, even after conclusion of study. Even in long term, none of these patients have encountered any intraocular inflammation, which has led to occlusive vasculitis. I've just tried to put this slide today morning only just to give you a rough idea that if you compare 2 years outcome from Hawke and Harrier versus this retrospective study, on left side is Hawke and Harrier and right side is our study. So quite different from this. We got much better visual gains, much better anatomical reduction. But again, proportion of patients who are not dry is much higher in this study as compared to Hawke and Harrier. This is combined data, both Hawke and Harrier and SRF and IRC both. And again, we could reach this Q12 and Q16 interval in larger number of patients. But again, this is a one-time achievement. It was not given as a fixed interval regime. It was PRN. So we never know that how many of them will maintain this in long run. So I think I'll skip this part. But being a retrospective study, you all understand limitations. And of course, strength is that it's a multicentric study backed by robust imaging data and Indian experience. So if I have to conclude, I think most common treatment protocol, what we saw was PRN in almost 53% cases, and loading dose followed by PRN in 34%. Visual acuity analysis I've already shared. Mean number of injections was 3.55. And this was again maximum injection-free interval. What we could get was around 19.8 weeks, which is very encouraging. And incidence of inflammation was 1.8%. None of the eyes with IOI lost any vision in this retrospective study. So that's all from my side. Thank you.
So, thank you, Dr. Dipender. I think it's a very important study because we've been really looking forward to the data coming out from our own country. And I think this really adds to that data. And we all know that because the immunogenicity of our population may be different to the Western population. And that's why probably we are not getting that much of IOI, which has been reported in literature. So I think that's something very reassuring, because I think initially to start with, when the drug was introduced, we were all hesitant to use it with the fear that it may cause vascular occlusions or IOI. I just had one question that in the 6 patients which had IOI, was there any predisposing factor, and also were they treatment naive, or they had been treated in the past with any other anti-VEGF?
I think we don't have a very detailed clinical information of all these 6 patients, but 2 had vitritis, and one of them were actually happened after first injection. Actually, I am not presented. We have data on after how many injections they developed this inflammation. So it was really surprising, and that one of these patients got IOI just after the one injection only. And as far as your question is concerned, we don't have clinical details, but we can always get, because patient's ID and everything is there with us. So we'll be definitely be publishing or presenting this subgroup analysis, what happened to those 6 patients.
Yeah, Dr. Dipinder, looking at the scenario of getting this intraocular inflammation only in 1.8% of the patient.
Yeah.
Earlier, we were quite apprehensive about looking at the inflammation. Our protocol was like 1 day, 1 week, 2 weeks, and 4 weeks. So looking at these inflammations, what message you would like to convey? Like we should have that standard protocol of giving less number of visits to the patient.
I think we got wiser by this happens. Whosoever is exposed first bears the brunt. So maybe I think our Indian surgeons, they got wiser how to choose patients, how to rule out diseases which can predispose patients for this vasculitis. And we were more comprehensive in workups. And these are all data from very specialized retina practices. I am still not sure when it goes to real world. Like, Avastin, it was doing very good for 6 years, 5 years. And then we started having a lot of problems when it went to masses. So I would rather say that it's a very good potent drug, and to save it from dying into, nowhere, we all should insist that this CNVM should, especially if you are planning to use brolucizumab, you should be doing it with a proper workup and very careful follow-up and in a rationalized way. So because probably that might have, it's a very highly selected group of patients where all our colleagues have used this.
So with the kind of improvement of 15.3 letters, which we have not got in any of the studies, and it's better than they should become the first line of treatment in all our AMD patients.
Yeah, it has the potential. I think more and more data.
Seeing this data, have you personally shifted to brolucizumab than other than?
Absolutely. This is data which is.
Your first line of treatment is brolucizumab.
I think I normally, it's not absolutely that I use brolucizumab for all neovascular AMD cases as first line. But now I seriously consider if one eye history is not good enough, or one eye, like patient was already switched to brolucizumab from previous injection and he's tolerating well, and now he develops a neovascular AMD in fellow eye. So those subset of patients, I have already made it as a first line treatment. But see, we still don't know the actual injection requirement for each and individual patient. Like we were discussing that treatment has to be customized and individualized. Some of them do very good with aflibercept also, and some will do very good with ranibizumab. So right now, I think if it is a type 1 CNVM, I would rather start with aflibercept if it is like treatment naive. But if it is a like fellow eye of a patient who has tolerated brolucizumab well, I will definitely not hesitate in starting a patient on brolucizumab.
I think, thanks.
Yeah.
I think brolucizumab is fast picking up. There's no doubt about it. In fact, center site data of 123 eyes also, we did not have any muscle block at all, and no IOI, because I photograph all these patients very religiously. And visual improvement, we have not been so lucky to have 15-line improvement, but patients do maintain good vision. The main thing is that duration you can extend from, say, 8 to 12 weeks in a lot of
It's
patients.
15 letters, not like
15
3 lines.
15 letters, yes.
Yeah.
So, but you see, there are a lot of patients, especially in the east part, people have shifted to brolucizumab primarily because of drying effect. Drying effect is the maximum, I think, out of all the anti-VEGFs available, including newer generation of anti-VEGF. Drying effect, there's nobody questioning. Yesterday we had this, webinar from Malaysia. Dr. Kenneth Wong was speaking. His experience of faricimab also. He also admitted there's no comparison between drying effect of.
Absolutely, that's there.
No doubt. And if you treat treatment naive, the results are slightly going to be better than the other treatment. I think with this, we move forward.
Can I make us one?
Yeah. Till the time Dinesh goes there, you can.
One reason
Depender, you can-
why you had a better improvement in your group of patients, maybe because the presenting vision would be worse.
Yeah.
Yeah.
So that is something which you can compare
Yeah.
with Hawk and Harrier and
Yeah,
yours.
yeah.
So of course, if it is worse vision to start with, then the vision
Absolutely. Our baseline
Margin-
vision,
Margin of improvement is not. Margin of.
no, in fact, our baseline was lesser. He's right. But they got affected by ceiling effect. That's why.
It has to be there. Then
Yeah.
only margin will get so
Yeah.
much.
But then I think to offset that, we had 40% previously treated patients also. But interestingly, I saw the data of previously treated patients. The colleagues have chosen good vision patients for brolucizumab, which is again, which was again the myth, against the myth that you try a new drug on a patient with poorer visions. Our colleagues have not done it.
The
So
other
that's-
message which can.
They
go
they
is-
chose it for a patient with better visions, good visions.
The other message which can go, is that there should be a low threshold for switching. You
Yeah.
don't keep persisting with the, say, either ranibizumab for, if the patient is not responding, 1, 2, 3, you can't keep persisting for 5, 6 injections. You should switch early so as to maximize the visual result.
So
Sure,
thank you,
thanks a lot.
Dipender. And I think even VRSI has collected now brolucizumab data, and I think will be soon coming out with it. It's including about 3,000 injections. So I think that will also add to the Indian data. So now I invite Dr. Dinesh Talwar, sir, and he would be speaking on real world scenarios with Q12 and treat and extend dosing with aflibercept.
Thank you, Manisha. At the outset, I must thank SAO and Dr. Lalit Verma and Dr. Azad for inviting me for this talk. We all talk about what the studies show. Then we talk about what the real world showed about these studies. I'm going to talk about what my real world is like. This is my disclaimer and the financial disclosure. Now, we all know from Marina and Anchor that you could get sustained visual acuity improvements with monthly ranibizumab. And that was the first time we actually showed some brilliant results in management of age-related macular degeneration. Subsequently, to counter this problem of monthly injections, we've tried PRN, we've tried 2-monthly, quarterly, and treat and extend. But the only thing which has stood the test of time was really treat and extend. And in this, the initial way this was designed was that you keep on increasing the intervals between the injections every 2 months, every 2 weeks, till you reach a 12-week or more injection interval. And for any recurrence, you decrease the interval. If there's a very severe recurrence, you could also go to monthly injections. But you don't normally extend in the presence of persistent or stable fluid. RPEDs were usually not considered as a reason for treatment. In my opinion, treat and extend regimes as they came were basically, well, they're more proactive and they were a good option for patients who are stable but not dry, which I just told from while I was sitting downstairs. For patients who don't need visits very frequently, where the cost of a visit is more than the cost of an injection, like in Western setups, it's very easy to say treat and extend everybody. You try that in this country and you'll probably make half the people, they will lose their money to a larger extent, and their living standards will get affected. In patients who have a dry retina, this thing is that it's better to have a wait and extend, who follow up regularly, but treat only when the patient needs it. And this is probably the best option for 2-eyed patients whose lesion becomes dry. Now, for 1-eyed patients, I understand we don't want to take any chances, so we want to keep on giving even when they're dry. It's like, it's a preemptive strike which is going on all the time. So the question is, how much can we increase the intervals between these patients? And various studies showed that with the fluid study, you could go up to 7 weeks as an average with ranibizumab. The Altair study showed us that with aflibercept, an extension of 12 weeks was possible in 60% of patients, which is great. And in 40% of the patients, you could go up to 16 weeks intervals. The Hawk and Harrier also showed that in a large number of patients, you could go to 12-weekly injection. And I think that has been shown by Dipinder, as the Indian results being better than that also. So my approach would be patient comes, you give the first 3 loading injections. Now we're talking of aflibercept, or you can be any of the other anti-VEGFs. And the lesion becomes dry. Now you have 2 options. If it's a one-eyed patient, I would like to take up for treat and extend. But if it is a 2-eyed patient, I may say they put in the PRN group, and you monitor monthly. So if the patient, if you've given this and the lesion is not dry. Now here again, if the lesion stabilizes in the next 3 months, you can consider a treat and extend approach. If it becomes dry, then the first paradigm, as I said, the algorithm where you now do a monthly follow-up. If you've given the 3 loading doses of aflibercept and you follow it up by a treat and extend regime, the patient's stable but not dry. Now you see what is the maximum interval you can go to. If you can go to more than 8-week intervals, it's worth giving this patient the treat and extend aflibercept. But if you're not able to reach that, this is a situation where either brolucizumab or faricimab, which will soon come into the country, are both available for us to try. So basically, either way, whether you are dry or you're stable or not dry, if you can reach an interval more than 6 weeks, that means you're at 8 weeks, 9 weeks, 10 weeks, it's worth keeping this patient on aflibercept. But if you're needing injections every 6 weeks, it makes sense to try either brolucizumab or faricimab. So let's see some of the patients where we've done this and what happened. So here is a real life. This is my real life, my patients, and these are just representative patients of how patients of AMD have behaved over the last 10 years. So this was a patient who got the initial 3 loading doses of ranibizumab, now requiring PRN ranibizumab every 6 weeks. So decided to shift to aflibercept. Now this was the initial lesion. Can you see? Yeah, this was the initial lesion. No, initially it showed great result, but requiring injections every 6 weeks. So shifted to aflibercept. And with aflibercept, what happened? We find that the first recurrence occurred after 8 weeks. We thought, okay, let's see what happens next time. Went back. This time, second time, the recurrence occurred after 10 weeks. And then we again persisted. Again, he had a recurrence after 10 weeks, followed up the 3rd time, and we realized when you go to 12 weeks, he gets a recurrence. So what did we find? That this patient has a maximum tolerance of 10 weeks. There's no point going beyond 10 weeks. We know beyond 10 weeks, he gets a recurrence. So we kept him on a 10 weeks. Now, incidentally, you'll say, when did we stop? We stopped the treatment when he died. Okay. When he died, the patient died. I mean, over a period of few years, he died. I'm just telling you that one of the end points you were asking is patient died. So follow-up is till the patient dies. Okay. So let's be very clear on that. In AMD, patients follow up, and I'll tell you something. I have never faced the situation of patients dying on me with PDT. And I did a lot of PDTs. But after ranibizumab and other anti-VEGFs have come, patients have lived on to 90s. They've died in their 90s, but they've died on me. And let me tell you one thing more about AMD patients. They are very, very loyal patients. I don't hear this thing about chhod ke chale gaye. It doesn't happen. It only happens with DME. It does not happen with AMD. So you are all going to, you're young, you're going to face this problem over time. Patients will die on you. Now, let's come to another patient. This patient, that was a great result. In this patient, we had an occult CNV. I started with aflibercept as the first drug, but unfortunately, we find every 4 weeks to 6 weeks, the patient required injections, despite the loading dose. And then, no, I'm saying it used to respond partially. A little bit of fluid would be left. In 4 weeks to 6 weeks, it would be back. So you'll see it responds, the fluid comes back. Now, as I said, there is no tolerance for fluid. I'm saying, no. You see the first one, you see over here, improved, but back again. So within 4 to 6 weeks, it's back again. I never got, in the initial year, I never got a chance to keep the patient off treatment for more than 4 to 6 weeks. Agar 4 weeks mein hota bhi tha, theek, wo 6 hafte mein phir वापस आ जाता था. Now, when that happened, I couldn't find any alternative. We continued this treatment. I didn't have any alternative of brolucizumab at that time. And this is the average, what happens. You can see from 2020, in the first year, 2020, she got every 4 to 6 weeks. In 21, the patient got again 4 to 6 weeks with one interval at 8 weeks. But by 22, the interval now starts increasing. It's now become 6 to 8 weeks. So this is the other thing I noticed over a period of time. Now this, you imagine this patient has followed up through the COVID epidemic, continuously followed up, continuously treated, and the patient's number of injections have started dropping. Now she's very often at 8 weeks. In 2023, the interval has come to 10 weeks, 9 weeks, then back again. Now, this is the other point, that it is not a straight line improvement. It is not straight line. It will go from 4 weeks, 6 weeks, 8 weeks, 10 weeks. It will go to 8 weeks, come back to 4 weeks. Then again improve to 10 weeks, then go back to 8 weeks. So what you are seeing is overall the trend is towards greater number of greater duration over time. So if you persist, the number of injections goes down. So this is just to show, this is the same patient. You can see over time, the fluid goes down, comes back. Again, is treated, comes back, it goes down again. But each time it goes down and comes back within a few weeks. And that interval over time has been going down, right? So this is what. Now let's come to this. This is a detailed course over 10 years. This is a patient whom we started initially on Lucentis, and she was shifted 4 years. He was shifted 4 years later to Eylea. And initially, there was a very good response to Eylea, complete resolution. But initially the RPED started coming back. Now what happens? We normally say don't treat the RPED, and I didn't treat the RPED. So when you don't treat the RPED, then the fluid started come back. When the fluid came, we treated again. And there was incomplete resolution. Now you can see here, 9 weeks later, there was a recurrence, full-fledged recurrence, again resolved, stayed okay, and stayed okay for some more time. Then we came to 8 weeks treat and extend. So now you'll wonder why. See, the month follow-ups on all these patients are monthly. So even though you've decided on 10 weeks, now at 8 weeks he gets a recurrence. The injection was at 8 weeks. Not that you wait another 2 weeks and then decide. So when there was we only treated when there was a recurrence with SRF. We didn't treat just an RPED. Now, as time goes on, in 2017, we've come to a 10-week interval. Very early recurrence. Again, you can see full-fledged recurrence at 10 weeks again. But so far it was improving. Now what happens? You go down. You were improving. Now you've come to 8 weeks recurrence coming back. Full-fledged recurrence at 8 weeks. Again, you treat. Again, at 8 weeks, there's a recurrence. And 4 weeks later, because there's still incomplete regression, you still treat. As I said, at no point do we tolerate fluid. If there is fluid, you treat. There's not that you're going to ek injection de diya, kam ho gaya to chhod diya. No. And then again, this time from 8 weeks, we managed to extend to 11 weeks. At 11 weeks, the patient got an injection, stayed okay. And then he came to a point when he said, I can't afford anymore. And so we can't afford anymore. I say, okay, then we give you ranibizumab more frequently. We put him on ranibizumab, came to 6-week initial one. We got a recurrence within 5 weeks. This early responded. But next time, this also improved to 8 weeks. That means even by shifting from when we went to, we started with ranibizumab, shifted to aflibercept, came back to ranibizumab. This time, ranibizumab could also last longer. And we even managed one time of 12 weeks. But unfortunately, after this initial 12 weeks, he again went 8 weeks. He would get a recurrence. And then once when we were absolutely okay, he got a recurrence within 5 weeks. And by that time, the patient support program had come. And now you can understand how a patient support program can make such a huge difference, how cost can make such a huge difference to this patient. He's a privately paying patient. And he said, "Aap wohi laga do." So we went back to Eylea. And this time, after putting him on Eylea, we went to 8 weeks, then 10 weeks, persisted on 10 weeks, and finally reached 16 weeks. And then we gave another injection, and then he did not, then COVID came, he didn't come back. And he came back once for a follow-up, and we have not had to give him an injection now for almost 48 weeks. He's not taken any more treatment. The question, in fact, comes, was he cured when he got that first 16-week interval? I don't know, because he stayed all right. He didn't need any more. So once we come to 16 weeks, I think even the literature accepts, if you've done 16 weeks twice, you could consider stopping. Now, this is a very interesting patient. Two eyes of this patient. One eye, you see, he was on Eylea, and we managed to go to 12-week treat and extend. It was dry lesion. Both the eyes have a lesion, so we couldn't stop his treatment. And then, despite this 12-weekly treatment, you'll see there's a lesion over here. Look carefully, and you'll see he's developed this. The central area has not got a problem. And incidentally, this patient has 6/18 vision in both the eyes. So this RPED came, he's being treated. Now what do we have? We have one eye, which is the left eye, which has gone to 16 weeks, then 21 weeks. He's actually not taken a treatment because he's now on, and I'm now thinking of not giving him any more because we've got 20 weeks twice. The other eye, he needs an injection every 7-8 weeks. And there is a recurrence coming of the RPD. So you couldn't have one eye active, the other eye dry. We can't stop treatment in the active eye. This is the last patient I have to show you. And this is basically to show how, you can see this patient from 2019. Patient's treatment was not started in 2019. Treatment was started way back in 2012, I think. But initially, she used to need an injection. She didn't even complete her loading dose because after the first dose, she was completely okay. She got only one more at that time. And then she used to need injections once in 5-6 months on a PRN basis. But with time that increased, she came to her worst point was 6 injections per year. And then you can see, again, the number of injections has started going down. From 6, it's come to average of 4, with an interval going up to 14-15 weeks on an average. And that has been maintained for the last 3 years. So you can have a patient going on more than 12 weekly injections, more than 12 weekly intervals. And that's a great thing to achieve for these patients. The question is, how often does this happen? So I can tell you this is in proportion to what I've been seeing. Patients who've got good vision, who've not got a very bad disease, they can maintain for many, many years on this. And finally, you can be okay on 3, 4, 5 injections per year. If you see the results from the studies also show more or less the same thing, that the proportion of patients according to their duration, it can be up to 16 weeks in 30%. This was the Aegis study. And 1/3 will be on 8 weeks or more, which is what we found, that you can manage more than 8 weeks in many of the patients. If it's less than 8 weeks, however, you must consider a switch. So when do we switch? If the frequency of injections is less than equal to 7 weeks for a recurrence, or even if it's a stable lesion and I need to give the injections 4 to 6 weeks, I will consider switch to brolucizumab or faricimab. And if the patient has been put on brolucizumab, I actually have patients who were on brolucizumab, did not get the perfect response which others are showing. And in those cases, I decided to I didn't want to give them monthly we'd already got studies saying that don't give monthly. So I alternate with aflibercept. So 1 month brolucizumab, 1 month aflibercept. This is the last slide. The key lesson that I've learned over the last decade and a half Aggressive monitoring is the key, not aggressive injections. Monthly follow-up is essential till the lesion heals, and then you can have 3-monthly follow-up. If it's a stable lesion, monthly follow-up is necessary. Greater the number of injections you manage to get in, more intensive and longer your follow-up, the better is the visual outcome. So when you say patients don't do well, it's you're not doing a good job. I'm being very emphatic about this. If you do not monitor your patients properly, if you do not counsel the patient on the needs, you see how the patient's behaving, you can change to treat and extend. More than 12 weekly injection frequency is possible in a substantial number of patients on aflibercept. And this increase to more than 12 weeks is not a straight line fashion. So don't give up just because you went down to 8 or 8 weeks. The next one will go back to 10 or 12. Eternal vigil and constant perseverance is the price that we pay for maintaining vision in patients with CNV, and the vigil is both by the patient and the doctor. Thank you very much, ladies and gentlemen.
So thank you, Dr. Talwar. I think that was a very extensive talk and which brought out those 5 important points very beautifully for managing these cases. And maybe we'll take up the questions after we've had the next talk by Dr. Obuli, and he will be speaking to us on Ocivia ranibizumab biosimilar. Oh, sorry. Dr. Ashish is joining online.
Ashish, are you there? Ashish, are you there? Yeah, Ashish is there. Thank you, Ashish, for joining. I think,
So, sorry, I'll just make a correction. So Dr. Ashish Sharma he's joined us virtually, and he'll be speaking to us on biosimilars, economics of anti-VEGF injections.
just a brief intro. Ashish, we know he's from Coimbatore, and he's the king of biosimilars. I think the maximum number of papers on the earth, I think he has published on biosimilars. And that's the reason I wanted him to be here, to hear from horse's mouth about biosimilars economics of anti-VEGF. Over to you, Ashish.
Okay. So thank you so much, Dr. Lalit, for the kind invitation. And a lot of things regarding the patient need are already being talked about. Raja covered very well, and Sir also covered very well. So before I proceed further, these are my disclosures. So I have disclosures regarding various biosimilar companies, India and overseas. And we have been trying to understand biosimilars from various fronts, whether it is switching, whether it's immunogenicity, whether it's the awareness, and whether it's the endotoxin, what can go wrong, and what kind of clinical trial designs which could differ and can cause some kind of nocebo perception. So various aspects. So we have been trying these to understand not only in India, but also across the globe. And I would definitely like to acknowledge the entire authors who have been part of these publications in the last 4 to 5 years. So biosimilars, as we all know, that they are the molecules which have essentially same safety and efficacy, which is a regulatory requirement, but they are not really exact the same molecule, but there's no clinically meaningful difference. Ultimately, what it provides you cost benefit. So that is the predominant kind of benefit that you get with these molecules. And in nutshell, a reference biologic in other countries, if you talk about, is almost any biosimilar takes 1/10 of the investment that an innovator molecule would do. So overall, you have a lot of cost saving. So that's why I think Dr. Lalit wanted me to emphasize on what kind of economics is involved with biosimilars and overall anti-VEGF. So why cost is a significant factor, and why are we really talking about economics at this forum? So as Raja really highlighted very well, that real world outcomes are inferior to RCT, and definitely we undertreat these patients many a time. And cost becomes a major factor true to the majority of the world, not only in India, even in overseas, even in developed nations as well. And if you look at the overall data, even the bevacizumab, Avastin is globally successful, especially in the United States. That is a testament that even developed world, they have significance of cost economics. And we are talking about the country where every third person has a risk of diabetic retinopathy and every fifth person has a threatening diabetic retinopathy. And we have a huge population to take care of, approximately 1 crore patients. If you look and go with the kind of incidence that we have in this country, although we are a poor data-driven country, but still, this is the kind of rough calculation that we have, that we need around 1 crore patients you require anti-VEGF injections. So why not Avastin if cost is a concern? It is an off-label drug. Many countries' healthcare authorities, they do not allow it. And in our countries and even in other countries, robust compounding pharmacies, they are not that strong. So it's very, very difficult when you talk about economics of India in this country, because as I said, we are not the data-driven country. We do not have registries like US has, Aegis registries and other registries that you can really get the right data that what is happening. Because we have patients on insurance, we have patients on cash, we have patients on different facets. So over the time, if you really want to judge something that, this is something which can give me some kind of economics idea, is something like what is the number of my average injection in one patient over the year. Even to prove that we do not have robust studies, probably, this is one of the data which was collected by Novartis, and we were also involved in that, and I'm presenting this in next Retina. So what it has given us some kind of headwinds like a ranibizumab usage. So ranibizumab use, this was to my surprise. I was expecting that at least, we would find, a lot of Avastin users, but to my surprise, ranibizumab users still highest in this country. And overall mean number of injection was 2.6, pretty low. As Raja already highlighted that real world, we are, quite low in terms of treated. We are not treating aggressively these patients. Why are we not treating aggressively these patients? Probably could be, some of the reasons, like patients are not affording it. That is one of the reasons. Or the same study highlights that patients had SRF in 72.6% of cases at the end of 12 months. So probably, they do not feel well. They do not feel treated at the end of 12 months. So, feeling of non-improvement in vision, which is again highlighted by one of our, friend Aditya also in a single center study, that non-affordability and no improvement in vision, they were, causing the maximum impact in terms of non-continuation of the treatment. And similar kind of result was that more than 3 injections, when it comes to, you have loss of follow-up to the highest percentage. So now, Dr. Azad was here, so I think he's still here. So I'm quoting his paper, 2007, back in 2007. If you look at one of his figure, it goes like this. So this was the anti-VEGF era when we started. Look at the exorbitant cost. Now, over the time, what happened? This is an important slide I would like to highlight here, that what has happened over the last 6 years, from 2017 to 2023. So if you look at, you have approximate advantage or price advantage in Lucentis 40% down, Resumab 30% down, Eylea 50% down. Why is that? Probably, this is again a testament that we needed some kind of better economics for our patients to continue them on therapy for a long term. And especially this has happened over the time in last 2-3 years. If you really look at the price differentiation, probably, I cannot say for sure, but probably the entry of biosimilars have made that difference. Now, another data, again, it's very difficult to get the right economics data, as I said already. So this is the survey that we have recently completed, and thanks to Dr. Manisha for her support on behalf of VRSI in collaboration with International Retina Biosimilar Study Group. So what we found was that overall, if you really look at the data from all the centers whosoever has participated, 50 to 100% proportion of ranibizumab usage, you have biosimilar uses in those practices. Originator has shrunken down to almost 0 to 25%. So that is what, the pricing has done, costing has done over the time. And this has not been achieved just by the pricing, but over the time, safety and efficacy also has given confidence confidence in biosimilars if you compare them from innovative molecule. As far as molecular preference is concerned, as of now, Resumab usage is approximately 80% if you really just talk about the biosimilar molecules. Rest everything is pretty low. So overall, you can say the data what we are talking about is basically the Resumab data in terms of the over the time, cost-effective analysis. As Sir was saying, Dr. Dinesh sir, that what Eylea for you has done means this slide I have just taken from Eylea team in the morning. You just look at their revenue since they started Eylea for you program. Their revenue was flat because of the COVID from 40 crore, and now in last 3 years they have done more than double revenue. So the question is, it is not just the revenue that we are highlighting here. Revenue means injections have gone up. Revenue means our patients are willing to take it more, compliance has increased. So that is what has done, if you have the right economics and the right pricing. Sometimes what happens, there is a flaw in economics calculation. This was a recent paper which was published by a few of our colleagues in US, and the title was The Biosimilar Paradox, How Anti-VEGF Biosimilars Could Increase Patient and Overall Healthcare Cost. If I just see the title, this might just, bias me the way Raja was saying that SRF, it has gone into our brain to so many retina specialists that we can tolerate SRF. But if you really go into the nuances, the entire paper was talking about in case on-label bevacizumab get approval, then probably people in US would not be allowed to use off-label bevacizumab. But the title looks really, really different. So we were not agreeing to that, because if such kind of message goes from the society, then it's not right, because biosimilars are already surrounded by nocebo perception. So this was our response. Now we were Indian centric in last few slides. Now just let's look at the world. We are not just the only poor country and poor economics. If you look at the data, I was in Sri Lanka last week. I was talking to some of the colleagues who came from UK there. Now in UK, if you look at the NHS guidelines, they have a step therapy and the primary usage is from biosimilar. We were not expecting US to be really aggressive in usage, but still you see the data presented by Carl Orr in ASRS 2023, already 15,000 injections are done. So economics, this is my last slide. Economics is not just the finance and the cost. If you really look at overall economics, what the continuous treatment can do is it not only just benefit overall the cost saving, but also in the societal value in saving a lot of money for the entire country to push it into some of the other areas. So now the news is that aflibercept biosimilar, first aflibercept biosimilar got approval last week. This is something which is going to change, especially the practice in this country. So I am a firm believer that biosimilars would change, especially once aflibercept biosimilars would come. A lot of economics can be managed and can come parallel. A lot of downtrodden people can come parallel in terms of the treatment and the continuation of the treatment. Thank you so very much, Dr. Lalit, for having me here.
Thank you, Dr. Ashish, for a very enlightening perspective of biosimilars. And as Dr. Lalit sir has very rightly pointed out, you are all like not only king encyclopedia of all the developments on biosimilars. So very encouraging to see, I think, a lot of other molecules coming, other companies getting interest, and we are expecting the cost to go down further, just like happened with the original molecules. Now we are expecting same thing happening with the biosimilars also, because you rightly started your presentation. That whole idea was to bring down the cost. And I think that is going to help a lot of our patients. So we'll invite, can we take, we'll have one comment from Dr. Talwar sir, and then we'll move on to next.
I think it's important to understand that India is a very price sensitive market. the general mass of patients would probably, if an injection was priced at 6,000, considering that the mean income is 20,000 a month, probably everyone would be able to take it. You increase it to 20,000, now only those who are at 50,000 monthly income can afford it. So the numbers have suddenly gone down drastically. But you increase it to 60,000, you actually removed a huge chunk of the market. Even if you say we have 50 million people available, yes, but that's a small number of patients compared to maybe another 500 million people whose families could have afforded it if we brought down the cost. So and what is happening is that with biosimilars, those costs are coming down. As those costs are coming down, probably the costs of the newer molecules will also have to be adjusted, because otherwise patients will shift to the cheaper ones. And that is where the difference will come. So we need to realize that every 10,000, 20,000 rupees that we bring down the cost, we are increasing not only the affordability, but we are increasing the healthcare standards.
Absolutely. And with volumes, I think we get more scientific benefits.
Incidentally, there's also a study which showed ultimately it's not the drug, but most important is giving at least some drug. So rather than giving nothing because the patient can't afford, say, aflibercept, please give him bevacizumab. He will still do better than getting no treatment.
Absolutely.
So
Sir,
I-
point taken, but
One line to this is that, believe me, if patient benefits by one injection, he will definitely come.
yes.
That is one, aspect. If you give him one injection, whether remaining of Avastin, remaining of brolucimab, whatever, काफी chance he will get some benefit. So he will come. Then he will come.
I also wanted to just make one comment that, still we are waiting that the biosimilar cost goes down much further low, because we do have a significant number of patients still being treated with Avastin. And we really have not been able to convert them even on a biosimilar.
So our job is to create a tug of war between.
Yes, yes.
You see. So Ashish, the real scene is based on a presentation. There needs to be tug of war, say, between Razumab to Osiva to other, that they should bring the cost down and benefit the patient ultimately, so that the compliance improves, so that the prognosis improves.
One question, Dr. Ashish. So you talked about lot about ranibizumab biosimilars, Eylea similars. So I guess there are few companies in pipeline which are taking out the bevacizumab for ocular use. So I think trials are underway in US. I think DGCI has given permission. So shortly there will be trials in India. So where do you see the role of bevacizumab meant for ocular use, which will be approved by the DGCI in short future?
So, Dr. Vinod, what's interesting means that's what something which was talked about in US in terms of on-label bevacizumab. I think that's what you are talking about in India, isn't it?
Yes.
So I mean, as of now, I'm not sure means whether we have some trials going on for on-label bevacizumab. But if that happens, means again that would again be another basket for us. But overall, again, as Dr. Sir has said, that again the pricing is something which drives this country. So if on-label bevacizumab comes,
Ashish, the Avastin trials have started in US to be as a trials they have started. Like Vinod was saying, they have started in US couple of months back, I think.
I think DGCI has
no,
given
the US already, FDA has declined. FDA has declined the approval for on-label bevacizumab for Outlook Therapeutics.
I think
So as of now, there is
I
in
think
interest of-
Orolab was planning to come up with those single aliquot.
Orolab has already applied to Indian FDA
Right.
for approval.
Yes.
I think that will take some time because they are going to price it very, very low, very, very low.
I think
Shall
with
I take,
more this approved molecules coming in, at least our colleagues will have easier time, counseling and managing these patients. Shift will now go on compliance and treatment outcomes rather than, escaping medical legal issues. I think you must have realized past decade, it has been really turbulent, anti-VEGF usage among our colleagues, especially in peripheries. They were still not able to decide should they continue using bevacizumab or stop. Is biosimilar good enough? So now with all reasonably good molecules available, I think now we'll actually focus on scientific issues, which is giving better compliance, better outcomes. I think it's a welcome change, I think.
Absolutely.
So we
Thank
can
you.
we move on to next?
Yeah, thank you, Dr. Ashish.
Thank you, Ashish.
Yeah, thank you, Dr. Ashish, for sparing time on Sunday. We'll now move on to Dr. Ramachandran. He'll be speaking on another biosimilar, Osiva. So,
my slides is it visible? Slides are not visible there.
You have on a pen drive? Or?
No,
Have on a
sir,
pen-
their computer. I gave it in my pen drive. I loaded it back.
You project the
मैंने पेन ड्राइव पे इनको दे दिया.
एक छोटा सा तो
वही लगाओ.
Okay, I think we should go on.
Yeah.
Yes.
Yes, sir. Good evening, everyone. My topic for today is Osiva, ranibizumab biosimilar. I think for a beginner like me, this is the right topic because as a beginning of our career, we can aspire to inject something very costly like faricimab or Eylea or whatever, but the patient will look at our experience, will look at our face, and then they will automatically ask for any biosimilar only. So introduction, anti-VEGFs are revolutionized the management of retinal disease. Efficacy and safety of intravitreal ranibizumab has been proven in multiple studies. Innovator molecule is less affordable to many patients in developing countries like India. Today in the era of biosimilars, we have tough competition between the use of innovator molecule and biosimilar, and also between the use of different biosimilars. Biosimilars are similar to the innovator molecule, possibly better also because they have the recent latest technology and the manufacturing. First ranibizumab biosimilar was developed in India. Since then, many biosimilars have been approved for retinal vascular diseases. Recently in US also, FDA has approved 2 biosimilars, Biovis and Cimaril, which have been for commercial use. So the topic which I'm going to talk about is Osiva. Osiva is a ranibizumab biosimilar which is made by Sun Pharmaceuticals. The CDSCO has granted approval in April 2022. We hereby present our experiences with Osiva. So our head Dr. Lalit also always keeps saying that we need to have our own data when it comes to any drug or any molecule. So this was a small study which we did in our center, and we tried Osiva in multiple diseases, and we started compiling the data. So it was a single center and a retrospective analysis between July 22 and March 23. And the inclusion was all the treatment naive and the previously treated patients for DME, CNVM, and RVO. The BCVA was and the central macular thickness was determined before injection, post injection day 1, 7, and 30. the intraocular inflammation was checked on each visit. Because it is a new drug, we also wanted to see how safe it is and how whether there is any incidence of inflammation also. So demographic, there are 13 eyes of 12 patients, and the mean age was 59 years, and predominantly male population, male patients. There were 6 patients of DME, 3 patients of CNVM, and 3 patients of RVO. Previously treated were 3, and treatment naive were 9. So as you can see, the visual acuity pre-injection and the post-injection at day 30. Universally, there is a reduction in the the improvement in the vision post-injection, and this is the mean. The mean is 0.68 pre-injection, and post-injection it has come to 0.61. And the central subfoveal thickness also, as you can see in all the patients, there is a barring for one patient in the patient number 9. Every other patient there is a reduction in the central subfoveal thickness. And the mean subfoveal thickness will also show that there is a significant reduction in the central mean subfoveal thickness. Coming to the treatment naive patients, they have responded much better compared to the previously treated patients, but the difference is not that significant. And coming to the CNVM also, there is a reduction in the central subfoveal thickness compared to the pre-treatment levels. And in DME also, you can see that there is almost 150 microns of mean average reduction in the central subfoveal thickness, and RVO also similarly. Safety profile, there is no patient developed any ocular adverse event, which is very important when we talk about a new drug, a new name. We are always very skeptical as to whether it will cause any inflammation. In our in our retrospective analysis, we haven't even come across even one case of intraocular inflammation. No systemic adverse events also in all the patients. Now coming to the OCTs of the patients. This is a patient having an active CNVM. This was a pre-treatment, the first slide. The second was after the first injection. This was after the second injection. And you can see that there is a significant reduction in the subfoveal blood as well as the fluid. And this is the patient 2. This is a patient of CRVO, uncontrolled diabetes, and with NVEG also. So after the first injection, there is a reduction in the central subfoveal thickness. And after the second injection, you can see almost there is no fluid at all. So it is as good as the, the innovator molecule eccentric. So it works. And this is another patient, this was post-lasered PDR. And you can see that there was a massive edema, and post-edema, post-injection, there was a drastic reduction in the central subfoveal thickness. And this is a case of a severe NPDR with diabetic macular edema. This was the pre-treatment, and the post-treatment, you can see that there is a reduction in the central subfoveal thickness, and also the reduction in the intraretinal edema. This is a patient of right type proliferative diabetic retinopathy. You can see that after subsequent injections, there is reduction in the hard exudates also. Intraretinal hard exudates have also started reducing, and there is a very significant improvement in the patient's central subfoveal thickness and the intraretinal edema. And this is a patient of acute BRVO, and you can see that there is a reduction. On presentation, there is a subfoveal and intraretinal fluid, and after injection, there is a drastic improvement in the patient's OCT findings, and also the vision also. Vision became 6/6. And this is the last patient, which is a patient of RVO with intraretinal edema, and post-injection, there is a reduction. And this is the patient of ischemic CRVO, and post-injection, there is almost all the fluid has gone after a single injection. So in the era of anti-VEGF, there is a tug of war between the innovator molecule and biosimilars. Most of the prospective randomized control studies have shown the efficacy of ranibizumab. The problem is the cost of the innovator molecule, because their the cost is so high. Most of the Indian population, they are not having the benefit of the drug. This is an interesting slide which was made by Elviser, which I have borrowed it for this presentation. This was just a simple cost analysis of the patient who came to our center, local patient and out of station. And over a period of time, we just calculated the amount the patient is paying apart from the drug, all the other aspects also, the travel he is going through, the OPD consultation fee and the OCT fee. And you can see at the end, there is a 40% difference when the patient is choosing innovator, biosimilar like Osiva compared to the innovator molecule, which is a huge our deal in Indian population. And the main purpose of biosimilar is to make the molecule cost effective. We must help the patient by asking them pharmaceutical company to reduce the cost of injection and to make the affordable to the patients. Conclusion, biosimilars are here to say biosimilar can be used as an alternative to innovator molecule, and Osiva is a very safe, efficacious and friendly to pocket. Thank you.
Thank you, Dr. Ramachandran. I think, very important to share early experience of these new molecules. Quite reassuring in this small study. So, because next talk is also on biosimilar, I'll invite Dr. Kunal Kaushik, who would be showing us some cases of neovascular AMD which were treated with Vizumab. And then we can have a couple of questions on these newer biosimilars.
Good evening, Dr. Slides, please. Yeah, Dr. Kunal Kaushik, talking about cases of neovascular AMD treated with Vizumab. No financial disclosure. The evolution of anti-VEGF started with pegatinib and then moved on to faricimab, which was approved in 2022. In between, we had ranibizumab, biosimilars, bevacizumab, aflibercept, broccolizumab, and then also we don't have those kind of results. Now, starting with biosimilars, biological products approved based on data showing similarity to reference product, which is a drug already approved by FDA. Also, they have proven to have no or minimal difference in safety, purity, or potency. The concept closely mirrors the generic drug approval following a chemical-based branded drug patent expiration. Recently, a survey by VRSI was done in which they felt they observed 60% of surgeons were using biosimilars of bevacizumab or ranibizumab and were satisfied with the safety and results. Starting with the cases, we had a case, 63-year-old male, complained of blurring of vision in right eye. BCVA was 6/18. On examination, it had a suspect lesion. We did an FFA, gave an occult CNVM, a type 1 lesion on OCT. On first, this is only the first injection response of Vizumab. BCVA increased from 6/18 to 6/9, and the lesion almost flattened with all the intraretinal fluid resolved. Moving on to the second case, 83-year-old male, BCVA was finger counting at 3 meters. A classic CNVM lesion on FFA, a type 2 lesion on OCT with intraretinal fluid and CNVM lesion. First injection response of Vizumab showed us improvement in vision to 6/24, the lesion almost flattening and the fluid almost resolving. Now, case 3, 72-year-old male, complain of right eye diminution of vision since 2 days. Best corrected vision, right eye was finger counting at 2 meter. Left eye 660, poor vision since 6 years due to atrophy following 12 injections of Avastin in left eye. So the right eye was very precious to us. We started on Vizumab. Best corrected vision at baseline was finger counting 2 meter. After receiving 2 injections, the lesion almost flattened out, and there was subtle subtle subretinal fluid at the baseline, but now we have seen drying up of this fluid also. Now, this patient is on. This is an interesting case. 78-year-old male, right eye 660, left eye finger counting at 1 meter. Both eyes showed aggressive disease. Left eye had vitreous hemorrhage settling inferiorly, maybe due to breakthrough bleed. On FFA, we can see the lesions, and in left eye, it is subretinal hemorrhage also. On OCT, we can see massive lesions on both the eyes. After 4 injections of right eye in right eye, we had a good result vision improving to 6/9, still distortion is there. And in left eye, it has increased to 6/60 from finger counting 1 meter. And still the lesion is there. So we'll be treating this patient for long. Another case, 57-year-old male, best corrected vision 6/6, left eye finger counting at 3 meters. On OCT, we can see a wrap lesion, an aggressive one. Patient received 3 injections. The lesions almost flattened 6/24. We put him on treat and extend. Next 6 weeks, he came back. He had another bleed. We started him injections, and after 2 more injections, he has come back to 6/9. The subfoveal lesion has almost gone, but that wrap lesion is still on treatment. So for adverse events, out of 52 injections, there was only 1 transient blurring, which resolved in 3 days. No anterior segment or vitritis. No anterior segment reaction or vitritis was seen in any of our cases. Post-operative pain was seen in 2 cases, which resolved on medication. There was no sight-threatening complication. To sum it up, the response after Vizumab injection have been very satisfying. Resolution has been seen in all types of CNVM. Adverse events observed were few and manageable. I feel it is a cost-effective option for patient needing multiple doses. This, in fact, increases the compliance of patient. Thank you.
Thank you, Dr. Kunal. That was a very nice presentation. And I think Vizumab is being marketed by Cipla, but being made by Reliance.
Yeah, yeah, same. Okay.
If anybody has any question for Dr. Kunal or Dr. Ramachandran, you can ask. Otherwise, we'll move on to Dr. Debulal. Thank you.
Thank you, sir.
Dr. Kunal. Excellent. So, Dr. Debulal, we can see you. Can you hear us? You have to unmute yourself. He's trying.
Yeah.
Please go ahead.
Good evening, everybody, and special thanks to Lalit sir for kindly, giving me this opportunity. So it's been really illuminating to hear all of you and hear the insights of my teachers and friends. So I'll be speaking on treating PCV in the current Indian context. This is the disclaimer and my disclosures. And basically, this is the agenda that I will walk you through. So basically, the question comes, why are we talking about PCV in India? Primarily because almost half of Indian ARMD patients have a multimodal imaging diagnosis of PCV. So this is something that we have to keep in the back of our minds when we treat ARMD patients, wet ARMD patients. And as of today, what options do we have in India? Well, obviously, PDT is not there, as we all know, and we have to fall back on anti-VEGFs. Now, just before we talk about anti-VEGFs, we have to go back in time a little bit and talk about the Everest study results. And we know that PDT was definitely superior to ranibizumab. But now we have better drugs. And we talk about the PLANET study. Aflibercept monotherapy was something that really resulted in good improvement of vision. And what's even more important is that 83% of these patients basically could do without rescue PDT. So that was something that really held hope for a lot of patients. Now, closer to the current day, brolucizumab and aflibercept in PCV. Well, like Lalit sir mentioned, this is all available on the Google. But just to reassure patients that you have good visual acuity improvement with both these drugs, and when it comes to reduction in the fluid and the CST values, brolucizumab is slightly ahead of aflibercept. So you have better fluid drying with brolucizumab. And in PCV you have the sub-RPE component also, and this is where also brolucizumab strikes. So the other more important thing that we've been talking right from Azad sir in the beginning, and Lalit sir also, and then of course, Dinesh Talwar sir mentioned that we need to cut down on the number of injections, and that is something where probably brolucizumab has an edge as of date. And you have a lot of patients, 76% to be precise, in the Hawk study, who could be managed up to 48 weeks on Q12 weekly intervals, and up to week 96, this was 68%. But interestingly, as Azad sir and Lalit sir, as well as Dinesh Talwar sir mentioned, that a lot of these patients actually don't need dosing even at 12 weeks. But let's move on to summarize. Brolucizumab can provide early response and faster resolution in PCV eyes. We have additional evidence, and who better to quote today than my dear friend Dr. Ashish, who actually has sort of told us why basically in PCV you have better results with brolucizumab, because it is, as we know, it's a drug that actually can reach the polypoidal lesions. And if you look at the Japanese studies, they have noted that there is significant reduction in the polypoidal lesions. And the other studies from the Japanese groups have gone on to say that they can actually there can be complete resolution. Up to 93% of the patients can have polyp reduction. And of course, a lot of these maculas are dry, 86% after the loading dose and 73% at 1 year, with a relatively lower number of, injections. So brolucizumab might reduce treatment burden for the PCV patients. And all of this because it's a small molecule which enables deeper penetration. So let's move on to a couple of cases, as this is basically real world experience. So let's look at this patient, 67-year-old gentleman, presenting with 6/12 vision. You have a notched PED here, and this is what the ICG and the FA looks like. And you can see there are a couple of small polyps here. And we treated him with brolucizumab. This is 2 months after the first brolucizumab injection. You can see there's significant reduction in the subretinal fluid. We treated him again at 2 months. This is again 2 months down the line after the second dose of brolucizumab. There's significant reduction of the neurosensory detachment, almost no neurosensory detachment. Maybe a little bit of reduction of the choroid also can be noticed, especially after the third dose. And vision has maintained at 6/9 partial, and the patient is also happy. And from here on, we can obviously think of a PRN regimen. But what about the polyp? Well, the polyp seems to have disappeared. Another patient, 63-year-old male, and here you can see a little bit of submacular hemorrhage also, and of course the polyp here. And this is the SD-OCT through the polyp, and you can see there's this area of subretinal, hemorrhage that's visible, and you can see here's of course the notched PED, and this is after the first brolucizumab. Very good reduction of the fluid, and the PED also seems to be going down. Vision is at 6/12 now, and after 3 doses, this is how the retina looks like. Pretty good. The PED is going down, and probably from here on, definitely we can think of extending the treatment and going PRN. But obviously, when you do PRN for these patients, like some of the previous speakers have mentioned, it's very important to routinely check and recheck these patients every 4 weeks. Now, this is something that we often see with brolucizumab. After 1 injection, you see very, very good improvement of the retinal features, and as the OCT tells a story of its own. So from here on, actually, you can straight away go into a PRN after just the loading dose. But the challenge comes when you are handling a patient that's really, really difficult to treat. So this is a patient that we've been treating for a while, 2016 to be precise, and this is when he came in. He had a couple of polyps, maybe here. This is of course a fundus camera-based ICG, not really too good. So here's the SD-OCT, and just a long story short, he had 1 PDT with ranibizumab to start with, and subsequently 44 ranibizumab injections and 5 aflibercept injections. So this is how he was in January 21 after all these injections, and pretty much the same if you look at the SD-OCT in January 2021. So this is when we offered him brolucizumab, and patient switched to brolucizumab. Through 2021, he received 3 monthly brolucizumab injections, and by the end of the year, this is how the fluid had come down. But he had significant cataract, and this is of course the Optos image. And I advised him cataract surgery, which I performed in January 2022. And this is in fact last month, August 2023, and vision is 6/12 partial. A lot of this improvement of vision has to go with the cataract being removed. And of course, if we talk about the number of brolucizumab injections for the last 30 months, it's 9 brolucizumab injections. So you can have intervals that are comfortable for the patient. So just to kind of wind up our patient with our experience with brolucizumab in PCV, we published this a little while back. Long story short, again, we have seen good improvement of vision, which was statistically significant in these PCV eyes, and so much so that 60% of the patients had good improvement of vision, 2 lines or more of improvement, which is something Dr. Deepinder also mentioned in his NAMD cohorts. And obviously, if you start early, like Dr. Raja mentioned initially, the improvement in vision can be slightly greater, as was noted here. The vision was better in the naive group. What about disease activity? Well, in SRF, IRF, and PED, we noted that there was significant reduction, and at final follow-up, 43% had no fluid to just quote the study. So the other important thing is that the injection-free interval, the mean injection-free interval was over 12 weeks. So this is something that's really heartening for our patients. And just to share with you, because we've been speaking about safety with brolucizumab, we actually published this year, and this again has an incidence of 1.7% of eyes. And the interesting thing is that the median vision recovered to pre-IOI levels by 3 months time point after they were detected to have IOI. So this is something that's really important and heartening to note, that a lot of these patients can do well. So in the current Indian context, brolucizumab is effective in treating both naive and recalcitrant PCV patients. It is suitable as monotherapy in PCV, and efficacy and durability of brolucizumab stands out when compared with other anti-VEGF agents. So thank you for your kind attention.
I have a question for Dr. Debulal. Very nice presentation. I remember in AO, Dr. Sadda had presented a subgroup analysis where he showed that with the decrease or with the subsidence of PED in IPCV patients with the use of brolucizumab, there was a decrease in visual acuity. So have you had any such kind of an experience in your series?
With the
Brolucizumab in IPCV?
Yeah, not really, because if I quote the study, there were 9% roughly of patients who actually maintained on the who actually had decrease of vision, but this could be because of the normal progress of the disease process also. In the PCV study, we did not have IOI, but the IOI study came later, and there what we saw was that out of these 13 eyes, 4 eyes actually had decreased vision. So all of these had fibrosis, but IOI, per se, they did better with steroids, and we did not have any persisting inflammation at 3 months time, of course. Does that answer your question?
Thank you, Dr. Debulal. And I think we'll wind up the session because we are
dot on time.
Thank you everyone
actually.
for joining us.
And
Yes.
I thank Manisha, Deepinder, Neeraj, Vinod, and all the speakers, also Ruchir. There are very important speakers who have stuck to the time, and we have finished. I know Dr. David Brown has already joined. Dr. Brown, your talk will become very important after the first talk. I hope it is okay with you that we will have first talk where current challenges and unmet needs of DME management will be there. I hope it's fine with you.
No problem.
Yeah. So because then your talk on newer treatment paradigms in DME actually will convey more information about that. So I'll request Dr. Avnindra Gupta, Dr. Sanjay Mishra, Dr. Shaurya to please join me on the stage, and we will start this second session on DME. And as I said in the beginning, our basic focus is primarily real world evidences. We are not going to talk too much on trials and all. We will see how we can improve the patient outcome by the all these injections. So At the outset, I'll request Dr. Manisha to be here as the first speaker about her talk on current challenges and unmet needs in DME management. And we are talking only on center involving non-tractional diabetic macular edema. Manisha. Yeah. And we would love to have comments from David Brown and Chaitra who have joined. Hello, Chaitra.
So good evening, everyone. And at the outset, I'd like to thank Dr. Lalit Verma, sir, for giving me this opportunity. In the coming few minutes, I would be speaking on current challenges and unmet needs in DME management. Now, we would realize that the treatment of DME actually confers a substantial burden on patients and healthcare systems. And these are the various issues or factors which actually lead to this increased burden, which I've outlined in this particular slide. So I will primarily focus on 5 aspects, which are, or 5 current challenges and unmet needs that we have in DME management, and that is pertaining to awareness, screening and diagnosing DME, treatment of DME, and compliance for a long-term follow-up and treatment, and last but not the least, monitoring the patients with DME. Now, I would just start my talk with this particular case example, which is a young patient, 45 years old, and he's a type 1 diabetic on dialysis for last 2 years, already in a state of depression. He was a computer engineer, not able to work for last 4 months, and had never been advised a fundus examination before, despite being under the care of a diabetologist and nephrologist. So this is the kind of awareness that we have amongst the patients as well as amongst our healthcare workers. And this is one of the studies which was published, which showed that approximately 45% of the patients with diabetic retinopathy who are attending the eye units have already actually lost vision before the condition was diagnosed. And that's extremely unfortunate situation, because these are the patients who are visiting the physicians and diabetologists on a very regular basis. So this shows the lack of awareness at the level of patients as well as at the level of physicians. But also another point why these patients are not really coming on time for management or for screening is because they're asymptomatic in the initial stages, and therefore, despite being advised for an eye checkup, they usually don't associate that as an important thing to be done. So how can we really meet this unmet need would probably be to spread more awareness through public awareness campaigns on social media. But most important would be to educate the physicians to make DR screening mandatory through a timely referral, or to have a DR screening at their own clinics, which is a more viable option. But the most important thing, or which is the need of the hour right now, is to have advocacy and a national program for control of blindness due to diabetic retinopathy and DME. And we have been long talking about cataract blindness, but I think it's time we moved on and had some kind of a program for control of blindness secondary to diabetic retinopathy, which is far increasing in number. Also, another important thing is that 20% of diabetics, they do have any form of DR. And of these, only 20% would have some element of vision-threatening condition. Now, since we don't know which 20% are going to be at a higher risk of developing a sight-threatening DR, we apparently land up examining all the diabetic patients. Now, what is important is that we have limited health resources, so it's important that we have better risk stratification of diabetic retinopathy patients. And the current grading systems that we are having are all semi-quantitative. They do not predict those at high risk of rapid progression to sight-threatening DR. Therefore, there's a need for newer approaches to identify diabetics at higher risk, and so that the resources can be better utilized and directed toward these patients. And in this aspect, we have something called as DR risk score, which we have started using in our clinic also. And this is extremely important because it tells you that the patient is going to be having a risk of developing DR in the coming years, at what level, and you can accordingly advise a review checkup to that particular patient. Now, there is a need also for proactive screening, which is not done. So till the patient doesn't start losing vision, he doesn't come for a checkup. So there is a need for an opportunistic screening of all the diabetic patients, and this does not need to be limited only to ophthalmologists. And we have to find alternate resources, such as screening by physicians and also screening in the community using non-mydriatic cameras, using telemedicine or artificial intelligence. And you would be surprised to know that only 1.3% of general practitioners are reported to use direct ophthalmoscope, which was very much a part of their practice a few decades back. And the chief current barriers which were found in the general physicians was the lack of awareness about DR and DME, a lack of time and training, and of course, a lack of incentive where they do not really feel motivated enough to do a DR screening in their clinics. So we have to educate the physicians and expose them to AI-based fundus cameras, which does not require any kind of training, and it is a very economical setup which they can develop in their own clinics and which can be of great help in doing a DR screening. Diabetes-associated comorbidities again involves multiple specialist visits. Adding to treatment and monitoring the burden can sometimes be very difficult, where the patient has to visit various clinics. So therefore, there's a need for diabetes care centers where all the complications of diabetes, including DME, can be managed under one roof. It will help to avoid the loss of multiple working days, loss of wages, travel expense, and easy logistics. There is a study published by Dr. Rajiv Raman, which apparently showed that there was a better compliance to regular screening and a timely management if all was done under one roof. Now, coming to treatment of DME, anti-VEGF injections, we know is the standard of care for managing DME in today's time. But under real-life conditions, the necessity for frequent retreatments and re-examination poses a huge burden on the patients and treatment centers. Response to treatment is also different in different patients, and therefore the patients may be very non-compliant to their treatment. So non-adherence and non-persistent to treatment, again, is a very difficult or a challenging situation while we are managing DME. So where exactly is the problem? Firstly, we do not have very standardized treatment protocols for managing DME. We don't know whether we have to treat them with a loading dose or a PRN from the start. We also don't know whether the loading dose is 3 injections or 5 injections or 6 injections. It is more well-defined for AMD patients, where we know that the loading dose comprises of 3 injections. And also, there is no definitive treatment duration when the patient asks us for how long. We do not have a definitive answer, and a patient apparently feels very demotivated when we tell them that lifelong you have to be under these injections. The second question is which intravitreal injections to use. And again, we also don't know whether a biologic is to be used. A whole gamut of biosimilars are there in the market, and when to shift these patients to a steroid injection. So the unmet need exists for many patients with DME, including the adherence to treatment, high injection burden, and suboptimal dosing, which can result into poor visual outcomes in these patients. This was a PATH survey conducted by ASRS in 2017, where more than 50% of the physicians, they felt that the need to reduce treatment burden and highlighted the need for more durable anti-VEGF injections, which would have resulted in better compliance of the patients. This is again an Indian study, and where they evaluated what were the various causes of dropout of the patients from their treatment. And the most important factor was the non-affordability, and the second being no improvement in vision, where the patients felt demotivated to continue the treatment. Coming to brolucizumab and the newer drug faricimab. Brolucizumab, of course, when we have the Kestrel and Kite study details, we realized that the number of injections required were far less in comparison to aflibercept, though the efficacy was well maintained. And more than 50% of the patients could be maintained on a more than 12 weeks of interval of the injections, which again has increased the durability of the treatment that we are giving. Faricimab, again, is a new drug which we have in our armamentarium, and the one-year results have shown that more than 50% of the patients receiving faricimab can be maintained on every 16 weeks of injection, and more than 70% of the patients of DME can be maintained on every 12 weeks of treatment. And this speaks that now we are slowly moving towards a more durable treatment and lesser frequent injections, which probably will result in better compliance. Now, why patient compliance is low for DME patients as compared to neovascular AMD? We know that it is far less because the patient is having multiple comorbidities and therefore has to do multiple clinic visits. Now, when I was just reviewing the literature, I realized that WHO apparently has identified poor adherence to treatment of chronic diseases as a worldwide problem. And the consequences of non-adherence to long-term therapies causes worse health outcomes and increased healthcare costs. So the WHO report actually tells us, and the adherence to long-term therapies is extremely important, and they have listed out various chronic diseases, but unfortunately, the retinal diseases, including diabetic retinopathy, is not there in the WHO list of chronic diseases requiring long-term treatment. And these are the 5 most important factors which have been outlined by WHO, which are responsible for the poor compliance of the patients. So there primarily is a need for integration or an integrated treatment approach, because we need to realize that DME patients are not only struggling with their ocular problem, but they are also having diabetes-related distress, leading to negative emotional and low self-esteem, along with anxiety, depression, and demotivation. So there's a need for integration of counselors, setting up of patient support groups, and use of conversation maps, which may help to improve compliance for DME care. And last but not the least, we have an unmet need of self-monitoring of DME patients at home. And gradually and slowly, we are moving towards these home OCT machines, which will help these patients to monitor themselves at home and reduce their clinic visits. So to conclude, DME patients are primarily in their working age population, and majority of them do have multiple systemic comorbidities. Much higher treatment burden, both on patients as well as healthcare systems, are there. And therefore, we need to have a more holistic approach rather than just managing their ocular problem. Thank you so much.
Thank you, Manisha, for this. In fact, each and every slide of yours had some message or the other. We will move on to Dr. David Brown and then take a couple of questions for both these talks, your talk as well as Dr. David Brown. And Dr. David Brown, I don't need to introduce him because all of you know him, have heard about him in various international forums. World Authority on Retina, virtually part of so many trials, and one of the most sought after speaker in the entire world. And we are very fortunate to have him, courtesy Novartis, to have him here. You see, all of us start whenever we diagnose all of us start this treatment of center involving DME non-tractional type with so-called first generation of anti-VEGFs, which were ranibizumab, then aflibercept, or even off-label Avastin also. But we will now hear Dr. David Brown, newer treatment paradigms in DME, because when to shift. So because all these patients may not be responsive to the first generation of drugs, whether to shift after 3 injections, 4 injections, what should be our threshold, and also whether to shift to newer anti-VEGF injections, whether brolucimab or faricimab or steroids. So that is what I think we would like to hear from Dr. David Brown. So over to David Brown. Thank you, sir.
Thank you very much. Can everyone hear me?
Yes, we can hear and see the slides also.
Perfect. Kestrel and Kite's been presented before. Certainly, I'm going to just briefly go over it and then just share some thoughts on the use of brolucizumab in diabetic macular edema. So Kestrel and Kite had a unique study design with a loading phase of every 6 weeks compared to all our other previous trials that had a loading phase of every 4 weeks. We tested brolucizumab loaded every 6 weeks versus aflibercept loaded every 4 weeks. Then aflibercept was given per the US label every 8 weeks. The Kestrel and Kite brolucizumab arms were, let me just move this around, were given every 12 weeks, and then were adjusted to 8 weeks if disease activity was seen. Disease activity was defined as increase in fluid or decreased visual acuity. Kestrel differed from Kite basically because of the difference in US and European Union regulatory. And Kestrel, the United States in particular, requires a dose response curve. So we tested both 3 milligram brolucizumab and 6 milligram brolucizumab with a 96-week endpoint compared to aflibercept, just like I said, Q4 followed by Q8. In KITE, there was only brolucizumab 6 milligram compared to aflibercept. So really the only difference was that there was no 3 milligram arm of brolucizumab in the KITE arm. Again, intervals adjusted to Q8 activity if there was disease activity. Then from 72 weeks on, stability could be increased to 12 weeks and then 16 weeks. Here's the clinical outcomes from Kestrel and KITE. Here you see that the primary objective was met, non-inferiority. Here you also see that brolucizumab 6 milligram actually had a little bit better visual acuity than aflibercept every 8 weeks. And so the primary objective was met in both Kestrel and KITE. That it was not only non-inferior, it was actually a little better, but not statistically different. Here's the mean change in thickness. Here we actually had a statistical difference that brolucizumab was statistically better, even with extended dose intervals in KITE, really right on top of one another in Kestrel. There were drier eyes with brolucizumab. Brolucizumab is essentially 10 times the molar anti-VEGF dose of aflibercept 2 milligram. So this wasn't unexpected, but we certainly saw here that more brolucizumab eyes had a reduction less than a pre-specified 280 microns at week 52 and week 100, despite decreased injections. Fewer patients had intraretinal fluid or subretinal fluid, again at pre-specified week 52 and week 100. And DRSS improvements also was comparable in brolucizumab and aflibercept. No statistical difference, although a trend was certainly there that brolucizumab was stronger. This is the number of patients that were able to be maintained on Q12 weeks in Kestrel was approximately a third with this criteria. It was a very tight criteria. We really didn't allow any fluid. In KITE, it was 22.7 over 12 weeks and 24% were over 16 weeks. Again, that's with a super tight criteria for maintaining that dosing. 70% of the brolucizumab patients who successfully completed their first Q12 week cycle were able to maintain. So if you could keep them on 12 weeks, most of them stayed there, again, with a tight criteria for reduction. Fewer injections by design. Aflibercept got 15, and KITE patients got an average of 10 over the 2 years, and 11 in Kestrel. That's with 5 loading doses, and that was our protocol, and we stuck to it in clinical practice. I don't think every patient needs 5 loading doses. If they're dry, I extend from the beginning. Overall safety profile, really pretty good, with the exception of some rare but real intraocular inflammation. Some of these are bad. And diabetes, though, it seems like there's a lot less than we saw in AMD, and partially it's probably because we gave a lot less doses. Where we saw the most trouble was when we gave it monthly. And so it's certainly not recommended that this drug be given at monthly intervals. Here you see the number of patients with adverse events. And, there was some endophthalmitis. That's from getting a needle in the eye. Intraocular inflammation, approximately 1 to 2% with aflibercept. Really about the same in KITE at 2.2, saw a little more in Kestrel with an incidence of about 4.2 to 5.3%. Adverse events of special interest, as you know, in the AMD studies, in particular Merlin, where we treated patients that had a lot of previous treatments and then treated them monthly, there was retinal vasculitis with inflammation and a low but real number. Here we saw no retinal vasculitis in Kestrel. There were 5 retinal vascular events, but these were not associated with intraocular inflammation. These were retinal vein occlusions or arterial occlusions like we might expect in a diabetic population. In KITE, there were 2 cases, 1 case of endophthalmitis and 1 case of uveitis, and the brolucizumab 6 milligram arm. Show some case studies. This is a patient of mine who was in the trial, went absolutely dry with just a few doses, maintained and gained 20 letters. This isn't an outlier. Patients do really well with this drug. Here you see that same patient noting decreased diabetic retinopathy, less microaneurysms, and maybe some decreased perfusion, decreased non-perfusion. Certainly the islets are much more normal at week 52. Here's a real world case. This is a patient, not very good diabetic control, A1C of 9.2. She's got quite significant non-proliferative diabetic retinopathy with cotton wool spots, engorgement of the vessels. Here you see quite a bit of diabetic macular edema. Single dose of brolucizumab really normalizes it. And we've really been impressed how strong this agent is. Again, it's about 10 times the anti-VEGF molar blockade than aflibercept 2 milligram. I wanted to show you what to look for. Again, intraocular vascular occlusion. Here is in the EU study. Here they had retinal arterial occlusion in less than 1%, so it's less than 1 per 10,000. Uveitis in about 1.5%. This is in the EU, again, retinal arterial occlusion seen in less than 1 in 10,000 cases in the EU series. Here's a patient of mine just to show you what to look for. This is not a DME case. This is an AMD case. 72-year-old AMD. She had had 30 prior injections before she was switched to brolucizumab. She received 3 brolucizumab injections. After she remained 20/50, but her anterior segment, her OCT was better. Here you see she has some vascular sheathing and a branched retinal artery occlusion. What I want you to look for is be very careful if you treat patients looking for subtle vitreous cell. Peripheral exam looking for vascular sheathing. We do an Optos fluorescein angiogram. If there's any question, if you have one at baseline, you can look back and make sure that that wasn't there. I want to show you, look for a hot nerve. I think the easiest place to see this is on an RNFL. I'm going to show you that. When in doubt, repeat the FFA to see if the nerve's hot. And again, if you have any inflammation with brolucizumab, I would stop the drug. And we use intravitreal steroids to treat predominantly dexamethasone implant, although I think any intraocular steroid is the best treatment. Oral steroid is really tough in this population of diabetics. Here's a patient, neovascular AMD. She was getting brolucizumab at 8-week intervals with good control of the disease activity, had some PED, but no subretinal fluid or intraretinal fluid. Here she presents at 8 weeks, and she actually has a little fluid, which was surprising. She's been pretty stable. Note she has some vitreous cells that weren't there on the previous OCTs. Here's what I'm talking about, noticing on the RNFL. This is her pre-existing RNFL within the normal range. And here, when she presented, even though you don't really notice it, you see it on the map, there's some subtle nerve fiber engorgement there. We just showing you a flickering between before and after, you just see this difference. I think it's one of the easiest ways to see either cystoid macular edema after cataract surgery, or certainly any subtle inflammation of the optic nerve. Here we treated her with an intravitreal dexamethasone implant, switched her to ranibizumab, vitreous cells went away, and note that that macular nerve, hot nerve sign resolved. In summary, Kestrel Kite showed that brolucizumab, very strong agent, comparable to aflibercept, robust anatomic achievements. There were numerically fewer patients with intraretinal fluid and subretinal fluid. 25% were maintained on a Q16-week interval despite a strict criteria. And the safety profile actually was better in diabetes than it was in AMD, presumably because we're giving a lot less dosing with no new safety signals. I want to encourage you to look for any inflammation in these patients and stop the drug. If you see it, it's rare, but you want to catch it so that you have less chance of an adverse event. Thank you very much. I'm going to stop sharing my slides if I can figure out how to do this. Perfect. Happy to entertain any questions.
Thank you, Dr. David Brown, for this very illuminating talk. You mentioned very clearly that people who could, you started with brolucizumab, but 70% of these could be maintained at Q12 after the initial treatment. Yeah, does it mean that the safety profile of brolucizumab? Because in India, what our experience is, we hardly encounter any IOI or vascular occlusions compared to what the label says that it is around 4%. So in real world scenario, are you encountering IOI, like, because one of your slide mentioned, IOI to be approximately 4.2 to 5.3%.
Yeah, that's when you design a trial to get a drug approved, you have to go against the previous drug. And the FDA in the US has something called a constancy principle, where you really have to treat the eyes virtually the same. And so that's why we did 5 loading doses of brolucizumab. Certainly, I think the less you give, the less chance you have of inciting an allergic response or the inflammation. And so where we saw the most in the United States with Merlin, where we give this drug 12 times a year, I think if you're able to quiet the disease activity with less doses, you have less chance of inflammation. Certainly in a clinical trial too, you're probably looking for inflammation more. With this drug, I would encourage you to look for inflammation since it's rare but real. But like you said, in India and in the European Union, it seems like there's less inflammation than what we reported in our trials.
Yeah, the other good learning was that in case, 2 points you raised was that in case optic nerve is hot or there are vitreous cells on OCT, then I think this may be a relative contraindication and we should shift to steroids.
Yeah, I'm sorry, what was the question?
No, other 2 learnings from your slides were that,
Sure.
in case the optic nerve is hot or the OCT shows some vitreous cells, then there's a relative contraindication for use of brolucizumab and we should shift to steroids in these patients.
Yeah, I mean, we've started using OCT and RNFL, the nerve, really to check for PVD. It's really the easiest way to see if there's a PVD. It was because we were doing RNFLs on everybody's how we picked that up. But it makes sense that the reason the nerve's hot on a fluorescein is there's axoplasmic flow reduction, which is picked up pretty easily by the RNFL. So,
any other question by anybody? Avninder? Mike.
So one thing, which patient of brolucizumab you exclude that you don't have to give this patient, because is there any segregation? These patients will develop more of IOI. If we have a lot of vascular leakage, because my concept is the molecule is pretty small. So if you have a lot of diffusion or vascular leakage, it can go intraluminal. The moment it goes intraluminal, it can cause thrombosis and kind of vasculitis. So any patient where you have an exclusion criteria that's seeing the fluorescein angiography picture or OCT picture, where you say, I don't want to give brolucizumab in these kind of patients.
Yeah, I mean, I actually was pleasantly surprised that the decreased signal of adverse events in this population. I thought the younger population would have, a more robust immune response. I was thinking exactly like you did, with more disruption of the blood retinal barrier, there would be potentially increased inflammation. We didn't see it, and so it may just be purely the amount of drug. We know from the DRCR protocols, as well as the extension studies of Rise Ride, our first studies, diabetics need less injections over time. And so if you can get them quieted down with less injections with this drug and then decrease that over time, we didn't see in macular degeneration, it was pretty rare to get these events in a patient that was doing fine. Most of it happened in the first year. That's not a hard and fast rule. There were a couple that presented late. So we're pretty comfortable if the ronbrolixizumab for a while and doing fine, you can probably not monitor them quite as diligently. In the United States, most patients are covered by either healthcare insurance or governmental insurance. And so the drug price is inconsequential. Certainly where it's a place where everybody's paying for their healthcare, the exams are cheaper than the drugs. So certainly more exams in your setting would be cost effective as opposed to just giving more drug like we do in the United States.
Dr. Brown, I've got a question. In fact, we have a speaker speaking about half dosage of brolucizumab. What is the dosage what you have been using? Because you have any idea of using half dosage of brolucizumab and how effective it is? Because it's going to have a lot of financial implications also in future.
I'm sorry, repeat the question one more time. My connection is not great. I apologize.
Any experience of using half dosage of brolucizumab?
Yeah. That makes a lot of sense. I mean, a half dose of brolucizumab is still 5 times the dose of aflibercept, right? And so I don't know, in the United States, you can't split doses or it's illegal based on the billing. But a half dose of brolucizumab would be, stronger than anything we have up until 8 milligram. 8 milligram aflibercept just came out in the United States. A full dose of brolucizumab is still stronger than 8 milligram brolucizumab, but half dose would be stronger than anything, including faricimab, than anything we have. So that being said, it's a small molecule. It may clear faster. But the initial anti-VEGF molar dose is super high, even with half dose.
I think one last question by Shaurya.
Yeah, Dr. Brown, I just wanted to ask that since you showed one of the cases in which we got a very good response with only a single injection. So would you want to go ahead giving those 5 doses, initial doses? Would you want to go in your treatment practice, not as a treatment protocol in a trial, but as in your own practice, would you want to go with lesser number of loading doses?
Yeah, I would extend that. I would see her at 6 weeks. And if there's no fluid, I would treat her, but then try to go 8 weeks. I would treat and extend from the beginning on these eyes. I don't see why not. If you have that kind of response with absolutely total resolution of the edema, I don't think there's a need for 5 loading doses.
Okay, thanks, Dr. Brown, for this very nice talk. And I think you will hang around for some time because there may be a couple of more questions after 1 or 2 more talks.
No problem.
Thank you. I think now we shift to Dr. Chaitra Jaydev from Narayan Netralaya. And very pertinent topic we have chosen for her is why should you choose brolucizumab and when to switch and where to switch. Chaitra, all yours.
Thank you, sir. After those two, very pertinent talks, I think my talk will have a little bit of overlap as to the burden of DME, which I think Manisha covered wonderfully, and Dr. Brown's talk as well, a little bit about kite and kestrel. So I'll brush through those slides. But my talk will primarily concentrate on why I am choosing brolucizumab and where to switch and when to switch. So, no financial disclosure. So we've already spoken about the increasing epidemic of diabetes, and we know that it's expected to reach large proportions by 2045. So we know as retinologists that we are going to be facing with a huge challenge of treating vision-threatening DME. So, what are these, and how does it affect the population primarily? So these complications that we see are in the productive age group, 20 to 79 years of age, and close to 20% of them are affected with any diabetic retinopathy. And we see that 7%, given the large percentage of diabetics in our country, DME is definitely a burden because at least 7% of them have diabetic macular edema. And how does vision loss in DME affect their life? Is near vision is difficult, driving, reading. They are also quite depressed because they're not able to keep up with their counterparts, perceiving colors, and also the risk of mortality, because we know that higher the disease burden, we know that they also have other systemic abnormalities, which in turn adds to the severity of DME. So the goals of treatment would be, of course, to reduce the amount of edema, to reduce the leakage, reduce the thickening on OCT, but most importantly, it is to stabilize or improve the vision itself. And success of the treatment, like I mentioned, there is also other coexisting systemic concerns that we need to take care of, whether it is hypertension, cardiac renal status, or lipid profiles. So the disease burden is managing the comorbidities that we spoke about, the burden itself, whether it's monitoring the treatment, the increased utilization of healthcare. Like Dr. Brown said, in the West, they have a lot of access to governmental healthcare or insurance, but most of our populations don't have it, and they're paying out of pocket. And this definitely adds to the treatment burden. So if we can get some sort of stability with the lesser amount of treatment, I think it will definitely work for our population at large. So even a simple 5-letter gain in vision can significantly affect the ability of our patients to read. A lot of them, especially in the elderly population, I think miss this the most. They keep saying that we can't read either their books or the newspaper, driving at night and driving under difficult conditions. So DME requires a treatment that provides maximal and sustained visual acuity gains with fewer injections than the current available protocols and the drugs that we have. This will therefore benefit patients, physicians, and the healthcare system. Now, when to switch? Should we even switch? Why can't we just start with the best available option that we have in our armamentarium? So look at this patient. This is not a patient with DME. I'm just giving an example. This patient, I would have been very skeptical about giving a brolucizumab, but with just one injection, you can see that the intraretinal fluid has come down dramatically. Now, this is another patient. Again, you can see the subretinal fluid, the PD, everything has started coming down with just one injection of brolucizumab. So when we've already had experience, in other diseases with this particular drug, why don't we, explore its option in DME as well? Well, about the drug itself, we know about its molecular structure. It's a single-chain antibody fragment, and it has more VEGF binding ability per volume compared to the others that we have. And it's also engineered to deliver more drug per dose. So with these advantages, I think we will be able to definitely look at an increased durability of the drug itself. So why, use it as a first line is we want to hit it hard. We know that delaying anti-VEGF treatment may lead to irreversible vision loss. And this was shown in the RISE and RIDE study, which showed that delayed ranibizumab treatment leads to suboptimal visual gains in patients with DME. So when we're looking at our patients, especially younger DME patients who are probably the breadwinners for the family, we want to give them the best possible treatment in the least possible amount of time, because delaying is only going to reduce their benefit from treatment itself. And the majority of BCVA gains in these studies were achieved after 5 to 6 monthly doses. So they were rather aggressive in the study. Secondly, we want some hope for non-responders and recalcitrant DME. We know that a large population do not definitely respond to treatment itself, whether it is 1, 2, or 3. So we have, very often confused whether to switch after 2, whether to wait for 3, as several studies say. But I think this is more a day-to-day, dilemma for us, and we base the decision on shifting drugs primarily on the patient's affordability and about the other eye status and other few factors. So clinical trials define no response to treatment when less than 5 ETDRS letters or less than 10% reduction in CMT is seen after 3 to 6 intravitreal consecutive month injections. So that is not what we can follow practically. In daily practice, 2 or at the most 3 consecutive injections is the criteria for most clinicians. So this is the studies that have shown that switching between anti-VEGF agents in management of refractory diabetic edema, a systematic review, this shows that an early switch is definitely beneficial. This is also another paper that was published in 2017, but I saw a lot of very important points which shows that switching sooner definitely gives more benefit to our patients. This was by Dr. Devdulal, who just spoke on off-label intravitreal brolucizumab for recalcitrant DME. He also showed a series of cases where in real world they were able to switch and show good response. We are also looking at compliance. We are looking at treatment burden. Patients can't afford visits every 4 weeks, scans every 4 weeks, consultation, and then of course treatment itself. So compliance, if we can improve by giving more durability, it definitely works. And treatment compliance in patients with DME is rather low globally and in India as well. And these are real world studies also that have shown that a majority of our patients are non-compliant. And treatment compliance directly affects the visual acuity gains in patients with DME. This was one study that had a follow-up for close to 30 months, and it shows that the change in ETDRS letters by therapy break-offs in DME was much, much lesser gained. So this is another paper that was recently published that shows that compliance and therapy adherence are most important for good visual acuity outcomes. Then we want to know which anti-VEGF gives us the best results, because we do have quite a few options available, but which gives the best results? Well, this is what Dr. Brown spoke about, Kestrel and Kite study, and we also had 5 sites in the Kite study in India itself. So I'm not going to go much into detail because he's already spoken about it, but it did show that Brolis was non-inferior. It had significant improvements in the CSFT, and higher proportion of patients had fluid resolution, and more than half of them were able to maintain at 12 weekly intervals, and it had a well-tolerated safety profile. Now, coming to some case examples, these are patients which were treatment naive. I have tried to space out the treatments to 6 weeks or more for almost all of these new patients, because we now know that we do get durable results in these patients. So this is how I was able to space out, and I think at the last follow-up, this patient is doing pretty well. These are a series of our treatment naive patients, and this was at last follow-up. After the third injection in this particular patient, I actually stopped giving treatment. I only followed up this because there was no center involving DME. This is another patient whom I would normally have preferred to give steroids because there was a lot of intraretinal fluid and subretinal fluid, and it seems rather chronic. But with one injection, I saw good enough response. And this was after the second. The subretinal fluid did go away quickly, but intraretinal fluid took some time, and then we saw gradual response. And this was, I think, at last follow-up. Of course, the patient is still on treatment. Now, this is another patient. You can see the cystoid spaces even on the hair image there, and you can see after treatment here again, I felt that the intraretinal fluid did not respond rapidly, but there was sustained response, and this was the patient on follow-up. This is another treatment naive patient. Again, you see there's this change in the coalescing of the cystoid spaces here, but then good response and visual acuity did improve, and this was at the last follow-up. Fifth case here, again, subretinal fluid is seen there here, and you can see response here. And this was, I think, in the month of June that we gave, and about mid-July, these are the results. And that was treatment naive. And what you do after switch, this is the one patient where had received 3 anti-VEGFs, 2 dexamethasones in the right, and in the left eye, 1 dexamethasone, when one anti-VEGF patient was not very happy with the response. So we thought, we did explain about brolucizumab and he was keen to try. So you can see the large cystoid spaces here on multicolor imaging. And this was the right eye and the left eye. And this is just after the first injection. So the response was pretty good, and the patient also feels at least the quality of vision is better. We are still treating this patient. This is another patient between 2020 and 22 has received 13 injections of anti-VEGF. So this was in 22 December, and you can see that the response here. We did keep a close follow-up on this particular patient because we were not sure how he'll respond. So in a matter of few days itself, you can see that there is good response, and of course did not require a repeat injection. Again, another patient with multiple injections of anti-VEGF, IVTA, DEX, all has been given. And again, you can see the chronicity of the edema here, and with one injection, you can see very good resolution, and the foveal contour is returning back to normal. So to summarize, for DME, we do need a drug that is super efficacious, because this is literally a disease that is there for life. So we need to treat this patient along with other comorbidities. We want a fast acting, we want a longer duration drug that can be injected less frequently with minimal or no side effects and lesser recurrences and economically. So this is the wish list that we all retinologists have. And I'm hoping sooner than later, we will be able to get one drug that matches all of them. Thank you so much.
Thank you, Chaitra, for this wonderful talk. So the key thing is, like you said, drug has to be super efficacious. So which is the super drug for you?
So, sir, the
Because
super
today,
efficacious.
believe me, efficacy-wise, a lot of these drugs have promise. Whether it is a first generation anti-VEGFs or second generation anti-VEGFs typified by brolucizumab or faricimab or 8 milligram. So which is the super efficacious? Would you like to start? Because today durability is the main thing. Ultimately,
True, sir.
duration is the main thing.
Yes. So with Pegenax or Broly, I've been able to space out the injections much more than before. With the first generation, I still think I need it every 4 weeks, especially in the severe DME patients. In patients with mild DME, it doesn't matter. So when we know that this particular patient is not going to resolve with one injection or is going to need frequent injections, then I would rather hit it with a more durable drug. So I am using a lot of Pegenax for DME. I'm also using it a lot for RVO. And especially with RVO, I've been able to space it over 3 months. So with that kind of
durability.
durability.
Slide, you said early switch. Early switch means 2 injections or maybe 3 sometimes.
Yes.
So your switch is to steroid or switch is to brolucizumab?
So it depends on what drug I've given as first line, sir. If it has been an anti-VEGF of a different molecule, I will try to switch to Pegenax. If it is not, patient is not conducive health-wise to shift to Pegenax, then I would try a steroid.
But the thing
Also,
is,
I look at
as David Brown said, because if the optic nerve is hot, or if you have more of HRF, hyperrefractive foci, or if
Then
there are
the
bigger
steroid.
cells,
then a steroid. And I'll also look at the phakic status and glaucoma, all those concerns also taken into consideration. Then I will base my decision.
Chatra, do you have any experience you have shifted from ranibizumab to brolucizumab, and patient has not responded to brolucizumab, and then shifted to steroids, or shifted to steroids and then given brolucizumab? So any kind of experience in?
So I've had patients where I at least with the higher molecules, I only wait for at least to see the first injection response. If the response is not very, very great, then I do switch back to whatever the patient had responded previously. I've had patients where I've switched back and they've done wonderfully.
David Brown, any comments on Chaitra's talk?
You're muted, Dr. Brown.
Sorry about that. No, I thought it was a great talk. Certainly diabetic patients, they got the reason people get diabetic retinopathy is 15 to 20 years non-compliance with a medical regimen. And so, anything you can do to treat them and get them to come back, certainly money is a big factor. And so if you can treat them with less doses or cheaper agents, certainly you have a better chance of compliance. Certainly want to look for, in my population, we have a lot of obesity, we have a lot of sleep apnea. hypertension, all those concomitant things, if you can get them to their general medicine doctor to work on their sleep apnea and their hypertension, you can also decrease the amount of injections needed. So great talk.
Yeah, diabetes being multifactorial disease, you have to take care of a lot of these 5-6 factors, which include sleep apnea also. Thanks, Chatra, for the wonderful talk. The next
Thanks
talk
for the
is-
opportunity, sir.
Next talk is, one more question. Yes, Manisha.
Dr. Chetra.
Yeah.
Nice talk, Chetra. I just wanted to ask you, since you've been using brolucizumab regularly for DME patients, have you noticed any reduction in hard exudate clumps in these patients on using brolucizumab?
So I haven't really quantified the hard exudate, Manisha, but what I used to initially fear of, the migration towards the fovea as such, I've not started seeing much with Viginex. I think that was a big concern with anti-VEGF, whether we're going to have migration of hard exudates. But I'm not, actually, to tell you frankly, I'm not quantified the reduction in hard exudates, but maybe I will look at some of the scans of these treatment-naive patients. But if you see the examples that I showed you, especially in the first patient, there was a lot of hard exudates, and by the final follow-up, there were none. So I'm pretty sure that if I go back and look at some of them, we should be able to get back on what percentage of them actually have hard exudates reducing or going away.
Yeah, we saw that slide. I think that is what prompted Manisha to ask this question.
It completely went away.
Thanks a lot. I think next talk is very, very exciting, and I would like comments both from Dr. David Brown as well as Chatra about the half-dose brolucizumab, because a lot of us do not have this experience, and we have with us Dr. Pradeep Kumar telling also half-dose brolucizumab. Should be exciting.
Very good evening to everyone. And thank you so much to South Asian Academy of Ophthalmology and especially to Professor Lalit Verma for inviting me. Today, I'll be speaking about the efficacy and safety of brolucizumab 6 mg vis-a-vis 3.6 mg in diabetic macular edema.
Lights.
Yeah, we are there. So the idea for conducting this study came from the approved dosage of ranibizumab in diabetic macular edema being 0.3 mg compared to 0.5 mg for CNVM. And we also saw in Kestrel study, as was beautifully shown by Dr. David Brown, that the 3 mg subgroup vis-a-vis the 6 mg subgroup behaved equally well. And in both the subgroups, the improvement was far better compared to aflibercept alone. So we hypothesized that the primary target in diabetic retinopathy being pre-retinal or intravitreal, the drug concentration which was required in vitreous to achieve saturation of receptors was lesser compared to choroidal neovascular membranes, and that is why we went ahead with this study. So this was the design of our study where 155 patients were evaluated, out of which 102 could be allocated to the two arms. And after dividing between 46 patients in each subgroup, 44 completed the trial and were analyzed in group 1 and 42 in 3.6 mg subgroup. These were our approvals, and we used the inclusion and exclusion criteria of Kestrel study, where the initial vision had to be less than 0.1 on logMAR to start the treatment, and the central macular thickness had to be more than 300 micron. One important thing was that all these patients had to be treatment naive. That means no prior intravitreal or laser treatment had to be done in these patients. Where we differed from the Kestrel study was that we started de novo with a PRN regime. We were seeing these patients at 4 weekly interval from 0 to 28 weeks. And whenever the patients met retreatment criteria, they were injected. So there was no loading dose concept in our study. And to measure the safety parameters, every time we were injecting brolucizumab, we were calling back our patients at day 1, day 7, and day 28 to assess for AC as well as the vitreous cells or any other signs of inflammation. These were our standard retreatment criteria, and a standardized ocular adverse event reading was done. To note here is that grade 4 has vitritis more than grade 2. So we had 44 patients in 6 mg subgroup, 42 in 3.6 mg subgroup. As you can see, both the groups were well matched for age and sex. Our being a service institute, there was a slight male preponderance in this. And coming to the metabolic profile, the patients had similar hemoglobin A1C values to start with. This is our box and whisker plot of 6 milligram subgroup, where we realize that starting from 0 week till the time the patient reaches 28 week, there is a gradual improvement in best corrected visual acuity. And a similar plot was achieved in the 3.6 milligram subgroup also. At any point of time, there was no variation which was significant at best corrected visual acuity. And the log chart shows a nice hyperbolic improvement from 0 to 28 week in both 6 milligram and the 3.6 milligram subgroup. Coming to the central macular thickness, this table shows that starting from 371.46 micron mean at 0 week, we improved to 273 micron at 28 week. When we plot this chart, the log scale shows a gradual improvement, and a similar chart is seen in the 3.6 milligram subgroup also. So we were able to demonstrate equal efficacy in both subgroups. But most important question which has been asked is the number of injections, did they differ? So the number of injections were similar in the two subgroups, with 131 injections in the 6 milligram subgroup compared to 127 injections in the 3.6 milligram subgroup. Very interestingly, if you have all noticed that once we came to the 28-week time, both the number of injections have slightly increased and our vision has also slightly reduced. This thing we have not been able to explain per se in our study, but this was an interesting thing to note. The ocular adverse events, these grade 3 adverse events were what were noticed by us. That is, the doctors, the patient never reported to us with any issues. There were only 2 serious IOIs, both were vitritis. In each group, we had one such case. We did not give intravitreal steroid, but we gave posterior subtenon 40 milligram triamcinolone. And both these patients improved very well to an extent that we had the courage to re-inject both these patients again. Few interesting observations were that these treatment-naive patients, once they were told that they have diabetic retinopathy and their vision is going to be affected because of their diabetic control, were able to get good metabolic control by the end of this study. So this might have played a part in our results. And we noticed a lot of subretinal fluid presence at the outset compared to what has been reported at about 4 to 6% to about 13.6% in one subgroup and 16.7% in another subgroup. So our take-home message is that brolucizumab is effective in diabetic macular edema. It can be used at a lower dosage. Why we talk about 3.6 milligram and not 3 milligram is because once you load this 6 milligram dosage in 0.05 ml, it is very easy to chalk it out at 0.03 ml because there is a clear marker there. You cannot come to 3 milligram between 0.02 and 0.03. That will be more of an assumption. A PRN basis can be started de novo and it is safe. The patients required roughly 3 injections on average in both the subgroups. And the adverse events, though they occur, they are manageable. And one small thing that I like to point out is that with our experience of close to about 1400 dosages now given, we have realized that initially our adverse events were higher. As we have been injecting this drug, maybe some post-marketing surveillance, but the number of adverse events has actually reduced rather than increased with our more number of injections. Thank you so much.
Thank you, Colonel, for this very exciting talk. The fact that you said that equal efficacy,
yes,
number
sir.
of injections similar,
yes, sir.
Side effects similar.
Yes, sir.
So we can possibly world over reduce the possibility of side effects also.
Absolutely, sir.
So that's a very, very big, statement, because I agree that, in the Crystal study as well as Rise and Ride, or the recommended dose for, ranibizumab is approved dose is 0.3 rather than. So this actually needs to be tested world over. Anybody has any observations apart from Dr. Mishra or Dr. Brown, yeah, cost also will come down. Is Dr.
I
David
have-
Brown on the line or Chaitra on the line?
So
Yeah,
one
I-
question I had.
Yeah.
Dr. Brown, please.
Yeah,
No,
Dr. Brown.
my only comment is, diabetics in a big population, 3 milligram didn't do as well as 6 milligram in Kestrel, right? And so it really, if you look at RISE RIDE and RIDE 0.3 milligrams actually beat 0.5 milligrams. And it's the first time we've ever not had a dose response curve in the history of anti-VEGF. And it's not because 0.3 was better. It's just tough to randomize diabetic eyes equally, even when you have 200 or 300. So in a smaller study, like I said, in the bigger study in Kestrel, 3 milligram didn't do as well. That being said, if it works for the patient, it doesn't matter, right? For that patient, I bet a lot of patients can get by with 3 milligrams or even 1.5 milligrams of brolucizumab, right? And so for an individual patient, I absolutely agree with you. On a big population, I think it didn't look like in Kestrel that 3 milligram was as good. But again, it could have been like RISE RIDE. It could have been a randomization issue. So.
Chaitra, any observation?
Sir, I just wanted to know that you made an observation that you had written in the final slide that up to 28 weeks, 3 doses were enough.
Yes, ma'am.
Yeah, so that is on your full dose or the reduced dose?
Okay. So in both the subgroups, the number of injections that we have shown are close to about 140. And one subgroup had about 44 patients, the other one had 42 patients. So roughly 3 injections in both the subgroups. So on an average, our patients were receiving just 3 dosages over an observation of 28 weeks. This is the message that we are giving.
So it could be either the full dose or the half dose.
Yes,
but
in both
it's
the
3
subgroups.
doses.
In both the subgroups, 3 dosages are enough.
Well, thank you, Pradeep. I think all of us will try all this and maybe we can share our experiences at a different platform.
Thank you so much.
Very nice observation. So now we have Dries Schroff from Schroff Eye Center to tell us about recent aflibercept trials. What has been the learning? We all know that aflibercept is one of the preferred molecules as per protocol T, one of the preferred molecules world over. In fact, has assumed #1 position in management of DME. But what about recent aflibercept trials? Dries about 8 milligrams, and so many things are happening.
Good evening, everyone. Thank you, Dr. Lalit Verma, for this opportunity. And I think we are going right opposite. I think Colonel Pradeep spoke about halving the dose, and now we are going to multiply it into 4x. So we're going right from down to up in the opposite spectrum of this. And other thing I want to just disclaimer is that I don't think anybody in this room has used this 8 milligrams. So I'm very sorry, I don't have any patients to show. It's just going to be the slides, but the data is very, very exciting. That's the thing which I would like to tell you. So why this concept of high dose? So whenever something, or now they're calling it, instead of Eylea, they call it Hylea. So, it's an exotic name. Instead of Eylea, now we're going to get something cool called Hylea. So basically, the kind of ground reality which kind of got this into concept is when they compared the 2 milligram dose, which is standard, with in the pivotal trials, the VIEW 1 and VIEW 2. And they found that 2 milligram had a higher proportion of patients with no fluid and shorter time to get dryness than 0.5 milligram. This was followed up by the CLEAR IT2 phase 2 trial, in which we found that 4 milligram was led greater reduction in central retinal thickness than 2 milligram after a single dose. So then, everybody wants to push the limit. So then they said that let's do the bazooka one. So it's the 8 milligram, 4-fold higher. Now, the problem is that it has to be a different molar. Otherwise, the volume would become too much and would cause IOP rise. So this was a different constituent. It was engineered. It is slit little higher. It's 70 microliters, not 50, but we normally use. And this had to optimize the solubility, viscosity, stability, and tolerability, which is why the company worked hard on this molecule. So like I said, I don't have any personal experience. This is from Dr. Diana Doe, who's faculty at Stanford University. And this is what the photon study. So I think there are 2 studies, Pulsar and Photon. But since this is the diabetic session, I'll be only covering the photon, which covers the DME results. So this, I think we all know, we've gone through this in the evening. It is a fully human recombinant fusion proteins, binds VEGF A, B, and PIGF. And this is a 4-fold higher molar dose, delivering 2 milligram, and it is in a 70 microliter injection. And it has already demonstrated functional and anatomical outcomes at dosing intervals more than 12 weeks. So this is the design of the trial, this is a slightly busy slide, but basically the traditional 2 milligram was given every 8 weeks, and they gave 5 initial monthly doses. But in the 8 milligram doses, both of them, please note that they only gave 3 initial monthly, and then they started extending it. And endpoint of the study was at 96 weeks. I think the inclusion criteria were very standard. They took adult patients with type 1 or type 2 diabetes, CME, central retinal thickness more than 300 micron in the study eye, and Snellen activity of 20 by 30 to 20 by 320. They, of course, excluded anybody who had recent treatment in any form like PRP, anti-VEGF, or steroids. So again, this is very, very busy slide, but this is nothing difficult. It just shows what I just said. The 2 milligram had the 5 loading and the 8 ones had 3. And these are at the interval described, these are the repeat injections. Again, baseline demographic, very busy slide, and I don't want to put this in front of you before dinner. So basically, it was a very well-designed study, and they took comparable baseline characteristics in all ways, including the vision, etc. So what is very interesting is the results. So the change in vision at 96 weeks was comparable in the 3 groups: the 2 milligrams, 8 week, and the 8 milligram, 12 and 16 weeks. And I think this is the most important slide. This is the basic crux of it, the number of injections through 96 weeks. So you can see in this group it's 13, and 12 is 9.5, and when you extend it, it's gone down to 7.8. So this was what they found: a large majority of those who are on this high dose maintained it through 96 weeks, and 89% had dosing intervals more than 12 weeks. And when they collated the data, they found 44% could maintain dosing intervals of more than 20 weeks at 96 weeks. So this is quite significant. This is like a very large gap they're maintaining, and meets the unmet need we have, as we've described today. The vision thickness was comparable. Of course, the most important thing is if you're increasing molar dose, what about the side effects? Because I think now inflammation is something which we're so scared about. So the ocular adverse effects were not comparable. And most important, there were no cases of retinal vasculitis, occlusive retinitis, or endophthalmitis reported till week 96. I think this is very, very important. Of course, this is, limited data, let it come out in the real world, but still, these are encouraging results. IOP was also fine, and non-ocular safety events were also non-significant. So I'd like to just conclude that the 12 and 16 week 8 milligram Eylea had non-inferior BCVA. 89% patients maintained vision more than 12 weeks, and the safety was comparable to the 2 milligram and the 8 milligram. And 44%, I think this is also very important, had intervals more than 20 weeks at 96 weeks. So it seems a promising option. I hope we can use it. And at the next meeting, we should be showing our own patients instead of the standard slides. Thank you so much.
Thank you, Darius, for a nice presentation. Why don't they do an head-to-head comparison trial between brolucizumab and aflibercept?
I think these are in the pipeline, but even this is not yet studied. The photon pulsar, I try to get it's not. So this is all very, very new and exciting. I don't know whether Dr. Brown is, I think in the US, they may have used it. We can take a comment from Sir if you like.
I was on mute again. Sorry about that. Yeah, I'm the primary author of that manuscript, so I know 8 milligram pretty well. It's a great drug. It's in the United States, it's $2,625 a dose. US dollars. And so,
$600.
Whether, what the price is, when it comes out in Europe or India, I don't know. It's a great drug and they price it accordingly. Is it, a head-to-head would be interesting. You probably a brolucizumab dose. The reason we did high dose was basically faricimab and brolucizumab, right? when you have competition and you have two drugs that have more anti-VEGF molarity, that's why it prompted Regeneron to test 8 milligram. Was pleasantly surprised with the data you showed that patients could go that long in both AMD and DME. It is a great drug, and I hope y'all get to use it too. So
you recommend with the existing data, what you recommend, Q12 or Q16?
I think we should, I mean, I would generally, because we are going to use it in a tailored manner, I would like to first, head for 12 and then try to extend it, depending on the tailored initially. And then when we get no confidence, we can kind of extend it. But yeah, I would definitely start with 12 in my practice. That's.
But believe me, with such kind of results being published with 8 milligrams, though there's a lot of excitement in the air now, because there's a tough competition between, all these increased durability drugs. Let it be brolucimab, let it be 8 milligrams, or let it be faricimab. You see, the claim today is for increased duration. And like Vrindra was saying, right time is here for somebody to do trials with each one of them head to head. So that like in protocol T we had all three, and right came the answer that, aflibercept is at the top. And we need to have similar kind of trials before anybody can answer this very clearly. No, Dr. David Brown?
No, I'm sorry. I agree with you.
So thanks a lot. Thanks, Dries, for sparing this time. I know Dries was busy, still we pulled him out. So after having spoken about all this anti-VEGF, and now we have a slight shift in the gear. And here is a man from Siliguri who would like to use Ozurdex as first line in DME. But we want to know, when do you want to use and when do you want to switch? So we have with us Somnath Chakravarti from Siliguri.
Thank you, sir, for that kind introduction, and thank you for the opportunity to speak here today. So as sir has, these are my disclaimers. So as sir has correctly said, and as the discussion so far tells us, that most guidelines which are primarily based on RCTs are very clear that we should always consider anti-VEGF as the first line of therapy, and consider Ozurdex only when we don't get enough result or poor response after at least 3 to 6 injections of anti-VEGF. So Ozurdex as a first line is considered in very few selected indications, like pseudophakic patients or patients with DME who are going to undergo a cataract surgery soon, patients who have a recent history of a stroke or a acute MI, post-vitrectomy patients, and patients who are reluctant to receive frequent injections. However, then the question comes, if we already have RCT-based guidelines, do we really need to look any further? I would believe that we do, because first of all, real-world data is not replicated. Real-world data does not show the same results as RCTs. In real-world studies, comparing anti-VEGF with Ozurdex in treating DME, the gain in visual acuity was always greater with Ozurdex. And this is irrespective of the baseline visual acuity, and the improvement or gains are even more when we use Ozurdex in treatment-naive cases compared to the gains with treatment-naive cases being treated with anti-VEGF. So in real world, it seems anti-VEGFs actually underperform. And as probably we have we'll all agree, the main reason is we require frequent re-injections when we are using anti-VEGF. More injections lead to poorer compliance. And in the real world, therefore, anti-VEGF treated cases often end up getting undertreated. Whereas Ozurdex appears to perform very well in real world, and this reason probably is that we need fewer injections when treating patients of DME with DEX implants, and fewer injections mean better compliance. So we have now 3-year-long real-world studies which show that 60% of the patients of DME treated with DEX implants can be treated with 3 or fewer implants. 40% of the patients require even just 1 implant. And the results, when we are comparing refractory DME treated with Ozurdex with treatment-naive cases treated with Ozurdex, are always better in the treatment-naive DME cases. As expected, the functional improvements are better with DEX implants in treatment-naive cases. Moreover, the number of implants required to treat treatment-naive cases with Ozurdex is significantly less than that required for refractory DME cases. So besides the fact that the real world data doesn't match up to RCTs, there are a few other issues with RCT purely basing our practice on RCTs. So even from RCTs, we know that not all DME patients respond to anti-VEGFs. So if we look at protocol I or protocol T, irrespective of the anti-VEGF, we see nearly 40% of the patients have suboptimal or poor response, and 30% have no response. So now we have OCT biomarkers which are suggestive of inflammation, and these may help us identify these poor or probably non-responders or partial responders to anti-VEGF early. And maybe those OCT biomarkers can tell us who are the cases we should switch early or start itself with DEX implants. So there are three such OCT biomarkers I like to highlight. Severe intraretinal cysts. So we know these cases show better anatomical outcomes with Ozurdex, and these cases tend to have frequent recurrences. So having a drug which has a long duration of action actually helps. Subfoveal neuroretinal detachment. So again, Ozurdex, when patients like this are treated with Ozurdex, they show faster resolution. And therefore, many authors now believe that if you have a DME patient with a subfoveal neuroretinal detachment, Ozurdex should be your treatment of choice. And patients with hyperreflective retinal foci in large numbers, that is 30 or more. Because these patients also seem to appear to respond better with Ozurdex, and the number of HRF response decreased significantly more with Ozurdex than with anti-VEGF. Third, in RCTs, we must remember when we are basing our practice on RCTs only that not all DME phenotypes were included in RCTs. And one of the very common DME phenotypes that we manage in our practice, day-to-day practice is DME with hard exudates. So these cases are usually not included in most RCTs. And we have seen now that Ozurdex leads to more rapid resolution of hard exudates than anti-VEGF. And this resolution is regardless of the HbA1c levels or lipid profile. So if someone asks me, are there any justification of starting treatment with Ozurdex in treatment-naive DME? I would say yes, because in the real world, Ozurdex outperforms anti-VEGFs. And starting early with Ozurdex yields greater visual acuity, visual gains with fewer injections. Then not all DME responds to anti-VEGFs, and presence of OCT biomarkers suggestive of inflammation should make us consider our reconsider our treatment strategies. And third, not all DME phenotypes were actually included in RCTs. Then what holds us back? I think all of us will agree the fear of complications. So if we come to cataract, so in the MID study, 2/3 of the cases developed cataract. But in the real world, the incidence of cataract is 0 to 50%, and it depends primarily on the number of injections you use. And most importantly, this cataract usually develop in the second year, and many of the patients actually the cataract doesn't progress to visually significant levels where you will do a surgery. But then cataract is probably not what holds us back. What holds us back is the risk of intraocular pressure elevation. And here we must remember that most intraocular pressure elevation is transient and usually returns to baseline by 3 to 4 months. More importantly, or rather most importantly, the risk of secondary glaucoma post-Ozurdex is actually very less in DME patients compared to RVO or uveitic CME being treated with Ozurdex. So that 97% of DME patients who had an elevated IOP could be very well managed with just simple IOP drops or anti-glaucoma drops. So in other words, if it is holding you back from using Ozurdex earlier in your practice, I would think that we need to rethink this also. So when do I consider Ozurdex in treatment-naive DME patients? Obviously, the 4 criteria which we have already discussed before, which are given by the EURETINA guidelines also. But I'll also include DMEs with inflammatory OCT biomarkers and some selected phenotypes. So let me just end with few examples. So here is a case of a DME, 7-year-old diabetic patient who had a history of cataract surgery 7 months ago. So you can see a lot of angiographic CME, subretinal fluid with intraretinal fluid and hard exudates. So I give an injection of Ozurdex. This is 30 days later. There is still some persistent IRF, but we know this drug has a sustained effect. And you can now see with that single injection 6 months later, the patient is doing very well. This is another case with gross intraretinal cystic changes. Again, we give an injection. We have already discussed these are the more resistant type of DME, which usually tend to recur again and again. So after 30 days, there is a definite reduction in the IRC, but it is still there. At 3 months, you can still see that the macular map clearly shows that the fluid is going down, but it has not gone away completely. So I repeat the Ozurdex. And this is after 6 months. You can see there is still some fluid left, but since the patient was feeling that he has now recovered significantly, so he didn't want another injection, though I could feel, I could see there was still some IRF there. So in DME with hard exudates, so this is another patient, grossly cystic changes of the macula along with a lot of hard exudates. I give an injection of Ozurdex, significant reduction in the IRF as well as the hard exudates. And this is after 3 months. Again, the fluid IRF is starting to come back, but look at the fundus picture, the beautiful resolution of the hard exudates, which is something we are always worried about migrating under the subfoveal space. Then diabetic macular edema with nephropathy. This is another reason, another common situation in our practice where more and more our nephrologist friends are insisting that we avoid anti-VEGF if possible. So here is one such patient who had an ischemic maculopathy IRF. So we gave an injection of Ozurdex. Because of the sustained activity, the patient had a sustained reduction on the IRF, but as expected, not much of a visual gain. Then diabetic macular edema with significant cataract, which Dogra sir will definitely speak more about after me. Again, a very common condition where giving an intravitreal implant really helps us because it has a sustained effect, which not only takes care of the DME itself, but also the post-operative inflammation induced by the surgery. So here you can see, this is the pre-op picture. The fundus was hazy because obviously of the cataract. So we do phaco-IOL with Ozurdex. And sir will again tell you about the timing. We usually give in our center the Ozurdex 2 weeks before because I give the Ozurdex. The phaco surgery is done by my colleague. And this is 30 days after the phaco surgery. You can see a beautiful resolution of the DME, though there is some IRF, but we know this drug has a sustained effect. Sure enough, after 3 months, you can see the fluid has disappeared so nicely. And finally, DME with post-PPV in post-vitrectomy eyes. Again, something I think most VIA surgeons will agree that this appears to be the drug of choice. We had a discussion with the brolucizumab, which also has a long sustained effect, can be useful in such a situation. My initial experience with DME, with the brolucizumab in DME has been very different to our experience in wet AMD, but that is for another day. So this patient had a vitrectomy for vitreous hemorrhage, but again, after 5 months, had a gradual drop in vision because of diabetic macular edema. So we give one injection of Ozurdex. This is after a month. And this is after 6 months with the fluid still there, but the vision recovering significantly. So I'll say consider Ozurdex early in DME because in the real world, Ozurdex outperforms anti-VEGF, and probably this may be because of the sustained effect of the drug, which leads to fewer injections and better compliance. Treatment of Ozurdex therefore also costs less than anti-VEGF in the long run. Treatment-naive cases respond much better to Ozurdex than refractory DME, with requiring fewer implants. And patients with DME and inflammatory biomarkers appear to respond better with Ozurdex. And most importantly, don't be afraid of the adverse effects because they can be easily managed. Thank you so much. Thank you, sir.
Wonderful talk, I must say. Somnath, I think there has been a shift of label. Previously, there was a conditional label with the Ozurdex. Now it's a unconditional label. That means you can use in any DME patient. But you made one very statement 3 or 4 times that DME outperforms anti-VEGF. And not all DME patients respond to anti-VEGF. You showed rise and right 30–40%. Yes. So does it mean that all patients of DME who we treat with Ozurdex, they all respond 100%?
No. That is not the message that I want to give. But there, as I said, there are some, and those especially which I was showing, sir, DMEs often come to us quite late, actually.
No, we didn't understand. You see, we didn't understand DME with hard exudates, with biomarkers, cyst, SRF, HRF, with CKD, with the cataract, with PPV. All these things, I think most of us accept.
Correct.
But without these conditions, as you said, early switch.
See, if they, sir, these are the indications where I have seen my friends and colleagues still persist with an initial trial of anti-VEGF.
Yeah.
My message is probably we can skip that part and start straight with Ozurdex in these groups.
So do you use anti-VEGF at all?
No, yes. Because if it's a mild NPDR, patient will control with some CI-DME, of course, I will not go and clear cleanse. We will not go for the Ozurdex in the first outset in all cases. It's not that treatment naive DME, all treatment naive DMEs we are treating with Ozurdex. But I feel that there are many doctors who are probably never going to think of Ozurdex as first line, which you are agreeing with me.
Yes.
So there are many indications where we should.
No, I 100% agree with you. This 6-7 condition which you told, I think first line can be
Yes.
considered, and in the usage of Ozurdex has increased quite a bit in these conditions, and awareness also. And I agree. You see, IOP is manageable, cataract is treatable nowadays. There should be no fear at all. What do you say? Sanjay?
Sir, Dr. Somnath, in fact, 2 of my papers have been published as far as Ozurdex has been concerned. One was comparison head-on with triamcinolone, and other was with ranibizumab in diabetic. So as far as safety profile is concerned, yes, you're right. And the other journal, which is a current safety profile, where 6,000 data of, so one of the Secodex study, data right. was given by me also in that Yes. case. So as far as the safety profile is concerned, I definitely say that Ozurdex is absolutely safe. We have not seen single case which required a surgical intervention. Correct. So all those cases where we had a transient spike in IOP was easily manageable with drugs. So definitely I would agree to you that it can be used as a first line of treatment.
So before I go to David Brown, Shaurya, what is the policy at RPC?
So I don't think that we have the first line of treatment as Ozurdex. But yes, but yes, in our setting, the problem is that we do give anti-VEGFs monthly, but they never get in the real world monthly because they go for the date, and then that date goes 2 weeks post that, and then we are never following the treatment protocol that we are actually following in any trial. So in those sort of situations, maybe Ozurdex can be given in the indication that you have mentioned. One concern that might be there is that we always see rebound edemas once the effect of the drug goes off.
This is a very frequently asked question, that rebound somehow is slightly more than what you see rebound in anti-VEGF. What is your take on that?
Beyond 3 months, unfortunately, it doesn't have much effect, but I would say that it goes out of control or it's not
So
manageable.
Somnath, what I do is I precisely know that rebound generally occurs between 3.5 to 4.
Yes, correct.
So I will give injection before the rebound.
Yes.
And that I think is the best policy.
That is what we follow, because we have seen, though you have said in one case you could follow it up to 6 months, in real world, I have not seen anybody going up to 6 months. It's around 2.5 months is the edema starts coming back. So that is the time we re-inject.
6 months was only 6 months. 6 months is only for bead study.
Yeah, that's
real world scenario. It's
less than 3 months. So you have to re-inject.
No, we counsel patients about like that only, that you can expect 3 to 4 months, as you rightly said, as we all agree. That we counsel patients like that only, that we will expect around 3 to 4 months you may require a repeat injection. But there are few cases where we have seen this sustained effect, but we don't tell patients that you will not require another injection till 6 months.
So let's hear David Brown reaction to what has already been spoken.
Sure. There are some patients that just don't respond to anti-VEGF that do amazing with steroids. And I wish we knew which ones. You really don't know. I mean, in the United States, we probably use steroids too late. We mainly use it for recalcitrant cases that may be too far gone. That being said, the reason we do that is the problem with steroids is that you cause cataracts in everyone if you keep giving Ozurdex, and you increase the intraocular pressure in a sizable percentage of the population, 20-30%. The other thing is, and this is just historical data from SCORE and other older trials, in a lot of patients, the effects of steroids tend to wane. They tend to do way better with the first or second steroid shot than they do with the 10th. And I don't know why that is either. I think it's a great idea. The nice thing about Ozurdex is, even though they say it's a 3-month drug, I consulted with Oculex in the development of it, and it's a 40-day platform. In other words, that individual device lasts about 40 days, but it's a lot of steroid. Dexamethasone is a very strong steroid. So you're giving a very high pulse that goes away, and that's why you have less intraocular pressure rises, because you're giving pulse treatment. Would it be better to have a continuous steroid release like the Utique device, fluocinolone device? I don't know if it's available there. Maybe, but then you end up with way more incisional glaucoma, right? So it's a double-edged sword, and great talk. That's why it's the art of medicine. You got to figure out everything you have in your armamentarium and use what you have to treat the patient. So.
Thank you.
One last question. If you have an intraocular spike at 2 to 3 months interval, what time you will re-inject Ozurdex, or you will wait for the spike to go down to normal and then you inject?
Yeah, and I have a glaucoma colleague of mine. So if the IOP is still high at 2 to 3 months, in spite of having given the AGM drug, anti-glaucoma medications, I always take his opinion and then time the medication. Sometimes if he says, please don't repeat the injection, then we have to simply not repeat the injection.
So
But as I think, sir, you will also agree that in our practical experience, this fear of IOP elevation is more in our brain than in the real world.
One thing is there, if there is a spike and if you re-inject at 3 months, then it will go on to intractable glaucoma.
I don't think so. You see, once there is a spike, believe me, I think everybody should say we'll withhold it. Don't talk to any glaucoma person. I don't think so. You need an opinion from glaucoma person for this.
Because
yeah, we'll ask Devan Tulli. But in any case, if there is a spike at, generally spike is at around 6 to 8 weeks.
Yes.
There's a large study done from Shankar Nitrale, which said all the Ozurdex patients, their spike normally happens at around 2 months or so. But if there is a spike, which is say more than 30 million mercury, I will not use even after 3 or 4 months.
1 or 2 patients of mine, in spite of the spikes on control of AGM, I repeated the injection and it went on to an intractable glaucoma. So the message is wait it to trough down and then you inject if you want really to, or shift on to anti-VEGF.
So thanks, Somnath, for this wonderful talk, and you had appreciation from David Brown for a wonderful talk. Next, we have Dr. Mangatram Dogra joining us from the Chandigarh, and he is an authority on his subject of diabetes and cataract. Remember, 101 million people in India are diabetics, and 11% of them have 11% of our population is diabetic. And there are a lot of situations where cataract surgery is planned in DME, and this talk may be more relevant for anterior segment surgeons also, because they are the people who encounter both DME as well, and they want the best kind of result. We have Mangatram Dogra with us, who will tell us from his personal experience, and Mangatram Dogra has decades of experience on dealing with this topic of cataract and DME. Yes, Mangat, thanks for joining.
Thank you, Dr. Lalit, for invitation. I hope I am audible.
Yeah, all good. Your slides are visible.
Okay, all right. So, as Dr. Lalit mentioned, I'm going to talk on the role of dexamethasone implant in DME with the cataract surgery. And I do have a disclaimer that I am a consultant with Elargan, but whatever I'm presenting here, these are provided all these things are my own, and Elargan does not recommend the use of any product devices outside the license indication. So I do have these financial disclosures here. So we know that cataract surgery in DME is a challenging issue, and progression or recurrence of DME is a profound disappointment for patients as well as ophthalmic surgeons. And if we defer cataract surgery till we have adequately treated, there could be 2 problems. One, the cataract would mature. We'll have a difficulty in monitoring diabetic retinopathy and may even jeopardize the surgical outcome in such cases. So I think we very well know that progression of diabetic retinopathy after cataract surgery is real one. And it is mainly due to the breakdown of blood retinal barrier and postoperative inflammation. This we knew right from the ETDRS study published way back in 1999, that if there is a severe NPDR, we're going to have a much more chances of worsening of diabetic retinopathy as compared to if we have a mild one, so which was very, very clear even that time. But we have a recent data. This is all over UK data on electronic records, and which mention exactly the same thing. The risk of treatment increased sharply 3 to 6 months after all grades of diabetic retinopathy. And the patient with moderate and severe NPDR are particularly at high risk. So this is the recent one which we have. And another thing which has come from DRCR net study, that eyes, those who are with non-central involved DME preceding cataract surgery were associated with increased risk of developing central involved DME around 16 weeks after cataract surgery. I think that is what we should remember. Usually the time frame for worsening, which has been seen in various studies, is around 2 months, and that is what is considered a reasonable period. So because of this, the postoperative worsening has been attributed to release of inflammatory mediators. So maybe corticosteroids are useful in reducing the risk of progression as acting as anti-inflammatory agents. I think we had several studies in past which talked of even you can see this study in 2009 here by Hong et al, where phaco did reduce the worsening as compared to intra and extracapsular. And what was real, and we should keep in mind that if we have more inflammation, prolonged surgery or a complicated surgery, then there is an increased breakdown and increased postoperative inflammation, and which will lead to real worsening. I'll show you some examples of my own patient. This lady, 41 years old, you can see telltale evidence of inflammation here. That is what must have happened here. So you can see her right eye, mild proliferative diabetic, and this is the way it has progressed in the operated eye. And right eye still, I mean, at the same time it has been done. You can see very mild changes, and what has happened to the left eye, it has gone on to the proliferative stage, and so much of changes have happened. So that is what can happen if there is increased inflammation. So I'll go to further. This is another case, and you can see here, right eye is having some sort of a moderate non-proliferative diabetic retinopathy, and the left eye, which had a cataract surgery, there was a posterior capsular rupture, and in this case you can see here the vision is hand movement, and this eye went on to develop neovascular glaucoma. So that is what complicated cataract surgery in moderate NPDR leads to very, very severe progression and to neovascular glaucoma. So at this time, there is a paradigm shift in managing such cases. In past, we used to defer surgery and we used to do laser. And then once the macula was reasonably dry, we would go for cataract surgery. At this time, either we gave prior or simultaneous intravitreal dexamethasone implant or anti-VEGF, and we have a better outcome as well as more confidence in doing the surgery. So I'm just again sharing from our own group. This particular patient, you can see here, had so many things. Grid laser has been done. 3 intravitreal bevacizumab were given and 1 triamcinolone in past. And this underwent with the simultaneous injection of Ozurdex during cataract surgery, and you can see excellent result. And this has been published from our group in Ophthalmology 2013, and which formed the basis for several of the other studies which were undertaken later on, and also resulted in approval for same indication not only in US but also in many European countries. And we also continue with the study, and this is recently published in our Indian journal, where we could achieve the same kind of a reduction in macro thickness and better visual outcome in patients, those who were given simultaneous intravitreal dexamethasone during phakic emulsification. At this time, we do give even before. This is one of the patient where, in fact, I had given Ozurdex 1 week prior to the cataract surgery, and then the cataract surgery was done by a cataract surgeon. Visual acuity was 636, and you can see here the patient did very well. Visual acuity improved to 612, and so sometimes all cataract surgeons are not comfortable doing the Ozurdex implant themselves and may not give on the table. What about DME treated with anti-VEGF before cataract? Because most of our patients are on anti-VEGF and they may be very well controlled. I think this recent study, which is published in AGO 2021, in real world study of DME and cataract, what has been seen here is with perioperative or anti-VEGF injection developed new or worsening DME. So what is happening is, even if the patient is very well controlled, so you have to inform the patient that after cataract surgery, even such a patient may also worsen, those who are very well controlled, and they may need more treatment with anti-VEGF or otherwise. So that is very important. One should keep in mind. So what about the comparison as far as the cataract surgery with DME is concerned? I think we have this meta-analysis which is recently published in Eye 2022. In this, it is very clear that the cataract surgery combined with DEX implants seems to provide better anatomical outcome compared with cataract surgery combined with anti-VEGF therapy, likely due to anti-inflammatory properties, as I talked to you. So that is responsible for much more breakdown of blood-retinal barrier. So recommendation, even otherwise, in a diabetic patient is that we have to do a good metabolic control. We should not hurry up with the cataract surgery. Patient should be managed by an experienced cataract surgeon. I have shown you some examples from our own that if we do not have experienced cataract and there is a prolonged surgery, more inflammation, then there is a problem. Also, the use of topical steroid and NSAIDs should be for longer time in all diabetic patients with cataract, not for 1 or 2 weeks, which is normally done at this time, because they have more chances of breakdown and developing changes in the macula. So we should be using for a much more longer time. And also from our own setup point of view in the country, avoid multifocals with DME, because I think they do much worse, and in the long run they have many problems. So even otherwise, with most of the maculopathies, the multifocals need to be avoided. And the use of pre-op or per-op intraocular dexamethasone implant, or if you want to give anti-VEGF, they are standard of care. But only thing is that, as I said earlier, that the effect would last probably for a month, and maybe changes may come later. So it doesn't cover 3 months. So I would say in conclusion, always inform the patient of likely possibility of decrease in visual acuity after cataract surgery in a diabetic macular edema patient, or those who have moderate to severe non-proliferative diabetic retinopathy. At this time, the evidence-based data as well as the real-world experience favor use of DEX implant, that is Ozurdex, before or simultaneously with cataract surgery for DME, because of the better control of post-op inflammation and 3 months efficacy. And in such patients, many a time you may not need all that prolonged drops or other things, which I was talking for other patients where you have not given this injection. So treatment of DME before or simultaneously with anti-VEGF transdermal laser may be considered a second-line therapy. This is because of whatever the real-world evidence at this time is. So this is just a slide which shows the information about the product. And thank you very much for patient hearing.
Thank you, Mangat, for the very loud and clear message that pre-op or per-op of patients of DME, even though they are doing well before surgery with anti-VEGF, then also you are saying that they should be given Ozurdex. Is that the message?
Either we should give Ozurdex, or they should be informed that they're going to worsen despite very good control. Why? Because they may need more injection.
Mangat, why allow them to worsen? My condition, because you
I
have
would say they should be given Ozurdex, but in case they want to, because of certain reason, they already have like compromised eye or a.
The reason I'm asking this is because I see a lot of people who are doing cataract surgery at the same time they are injecting anti-VEGFs also. So you are saying that they should not. They should be, treating with Ozurdex.
Because they feel more comfortable. Ozurdex is little difficult to inject, so that's how. And secondly, but they have to inform the patient that they'll keep on getting more number of injection even in the post-cataract surgery period, even if they are giving anti-VEGF. But why we prefer Ozurdex is because it covers those 3 months, because most of the time this edema would come around. You see, as I mentioned,
Mangat, this raises a pertinent question. I think Largan has to undertake this exercise, because most of the cataract surgeons are afraid of this 22 gauge needle.
Yes.
So either they have to teach, or because they would not prefer that, retina surgeon has to come in between, inject Ozurdex and then cataract surgery. So that is the big challenge.
Actually, what I would suggest, most of the time, if it is a DME patient, that patient is already under the care of a person who is treating for, you see, retinal problem. So they should be, in fact, telling them to inject it 1 or 2 weeks before and then do the cataract surgery, because most of the DME patients, they do require retinal person's intervention. So should not be a problem. And because if they hurry up with such a surgery, I think they are going to get a bad name because they're going to worsen and there's going to be a problem. So that's what my message would be very clearly. Yeah.
Any comments by Dr. David Brown? Are you convinced of what Dr. Dogra said?
Yeah, I mean, cataract surgery is inflammatory. So sure, anytime you can give, you know, even for non-diabetic patients, I think it's a great idea if you have the opportunity. You know, most people give some kind of steroids. I think Ozurdex is a great one. You know, the diabetics, you know, you can keep their diabetic macular edema under control with anti-VEGFs, but it makes sense to control the inflammatory. When you're poking the tiger, you might as well try to eliminate whatever bite you can get.
Any comments from the audience? There are a lot of cataract people here who would like to, you know, comment. Dr. Ajay, or any comment on this?
I
give
give suprachoroidal triamcinolone in my patients, and just to tell you that you were discussing about Ozurdex being effective for 3 months. I've had patients where we centrifuged the triamcinolone, gave in the suprachoroidal space, and the effect has lasted for 6 to 7 months.
Have you published this data somewhere?
Now I have collected few cases. I'll send it for publication. But
Ritu,
it was very effective.
Ritu is busy. What do you do in a patient of diabetes with cataract? You ask Ajay to manage, or you do yourself? Team effort works. So I think what Mangat Ram Dogra said and what our friend from Siliguri, Dr. Sona said, you see, till the time cataract surgeons, you know, are trained to do this 22 gauge needle, what Somna said, 2 weeks prior, you give this injection.
Lalit, we do such complicated phaco surgeries. Giving Ozurdex is no big deal.
Question not a deal. How many? I have not seen Ritu. How many cataract surgeons are giving this 22 gauge? I have not seen.
I think if you open the Pandora box, then retina surgeons will, you know, lose half their work if cataract surgeons give all the injections.
So RPC experience?
So generally when we have macular edema and cataract, first we would treat the macular edema and then only go ahead with cataract surgery. If it is a non-center macular edema, we might just do a cataract surgery with a simultaneous anti-VEGF because that's not a big deal. Since it is costly, I would not say that we can offer that you know, option to the patients, because where it's free, you can probably go in for a simultaneous cataract with a DME. I would with an Ozurdex, sorry. And in cases where there is PDR and cataract surgery and DME, I would probably say in that case, maybe going it with an Ozurdex is good, because you will be tackling not just DME, post-operative inflammation, as well as the sittings of laser that might aggravate the edema.
So can I make a point? Just to request Dr. Mangat Dogra to comment, is that I don't think a take-home message should go back that a patient who has got a diabetic macular edema, which ideally should be treated, we should give an Ozurdex and operate on the same sitting. So because I think if we have, as Shaurya said, that we should be able to, so you know, it's not that previously we used to wait for 3 months before the diabetic macular edema is subsided before we did cataract surgery. Yes, the wait period has reduced, but I think we have to wait adequate time till it is reasonably controlled before we operate.
Actually, I would like to comment on this. You see, there are several studies on this. In fact, they have shown somewhat better effect with the simultaneous injection. And in fact, I happen to be with a person who has started all this way back in 2012, who gave on the table itself the injection simultaneously and has seen very good effect. But now at present where I work, we give usually 1 or 2 weeks before. That works equally well. Even if you go to the literature, they have given any time a month before to a week or 2 weeks, as well as on the table. So I think it all depends, I think, how comfortable one feels, because many people are not comfortable. They feel other things also. pressure may rise, globe may collapse, other things may happen. So I think if you can do it a week or two before, and already a person who is taking care of that diabetic macular edema patient, if he does that, then the cataract surgeon will have no issue as far as the apprehension.
Let me ask Major General Mishra about, because he has experience of thousands of such patients.
Yes, yes.
I will definitely say that if there's a macular edema is there, you have to tackle macular edema before cataract surgery, because we do a lot of cataract and diabetic cases together. So we just settle the edema first and then do the cataract surgery. And then definitely you can add on Ozurdex, concurrent Ozurdex implant together. But having edema and operating cataract, even if the cataract surgery is uneventful, we have seen that sometimes the edema, increases, and then causes a lot of discomfort, especially the patient. He says, "Okay, my vision has gone down," and those jittery patients can eat your head. So you have to tackle those edema first, and then take up for the cataract surgery. That's very important. Secondly, also that sometimes giving Ozurdex, that 22 gauge needle, can produce little more pain than the cataract surgery itself. So you have to tell the patient after the cataract surgery that it's going to have a small amount of pain while doing that injections.
Once in a while, you may find that after you've given the Ozurdex and you've told the patient, I'll do the cataract surgery 2-3 weeks later, you find the vision's improved so much he doesn't need the cataract surgery.
That's bad evaluation, actually.
So let me tell you, the lot of early cataracts which get operated are actually more macular edema than cataract.
Yeah.
And therefore, it's important that you first manage at least give one, even if you give Ozurdex, give the Ozurdex, see 3 weeks later. If the patient is not improved, you can give him you can go ahead with the cataract surgery at that time, because the macular edema would have gone down. It actually makes more sense to give the injection first, because as Dr. Dogra himself said, sometimes if you give this after your cataract surgery, it may just come out. The lens may come out at the same time when you give the injection. The injection will go in, the IOL will come out. So better thing is that you give it 2-3 weeks before. And from Shaurya's point of view, it doesn't make sense because their anti-VEGF costs $1,500. Our anti-VEGF costs 30,000. So in his setup, it definitely doesn't make sense to give Ozurdex. The better thing is to give 2 injections of anti-VEGF. Do the cataract surgery 2 weeks after the anti-VEGF and give another anti-VEGF 3 weeks later. That probably will give you better results and cheaper results than giving an Ozurdex, which will work. Nobody denies it will work for 3 months, but not in the setup that he is in.
Okay, I think with this, we will, try to come to end of this, because this is a non-ending question answer session. And it's my proud privilege to thank all the chairpersons, panelists, speakers, and especially Dr. David Brown from US, who early morning has been sitting with us for more than an hour. Thanks, David, for being with us and answering a lot of our queries. Thanks, Mangat, for crystallizing a lot of points with regard to DME. And we are also thankful to our partners, namely Novartis, Allergan, Bayer, Intas, Cipla, and Sun Pharma for their support. And also thankful to Professor Azad, the president of SAU, and the help rendered by Mr. Kirpal, Sajid, and Bhupinder for good conduct of this meeting. And will fail in my duty in case I don't thank Mr. Badera and the staff of IHC, and Mr. Ravi Grover and Naresh for these wonderful audiovisual arrangements, and also providing very good net connectivity. So thanks a lot, everyone, for joining today. And we can now break for dinner. Thank you, Mangat, and thank you.
Thank you. Thank you. Thank you
for this
very
wonderful.
much. Thank you.
We'll meet again.